Alright, so we're starting high yield facts in pulmonary. Obstructive lung disease. It's characterized by airway narrowing or collapse that causes impaired expiration and it results in air trapping. This figure illustrates the role of lung volume measurements in the diagnosis of the lung disease. And this table and this figure contrast obstructive lung disease with restrictive lung disease. Here the key fact is forced expiratory volume over functional volume capacity ratio is less than 70% suggests obstructive ventilatory defect, for example asthma, bronchiectasis, or COPD. If this ratio is more than 70% or equal to, suggests restrictive ventilatory defect, for example, interstitial lung disease, neuromuscular disease, obesity, or scoliosis. So the way you remember this is, if you put a scale from 0 to 100, and this is 70% right here, everything right to it is going to be restrictive. So right, R for right and R for restrictive. Everything left is going to be obstructive. Okay. Asthma. Reversible airway obstruction secondary to bronchial hyperactivity, airway inflammation, mucus plugging, and smooth muscle hypertrophy. Most often diagnosed in childhood or early adulthood, but can present later. Okay. History and physical examination usually presents with dry cough, episodic wheezing, dyspnea and or chest tightness, often worsening at night or in early morning. Physical examination, wheezing, prolonged expiration. Okay, that's one of the classic presentation. Decrease in inspiration-expiration ratio, increased accessory muscle use, tachypnea, tachycardia, and hyperresonance. Signs of severe disease, less than breath sounds. Decrease in breath sounds, cyanosis, decrease in O2 saturation, hypercapnia, where there is an increase in partial pressure or carbon dioxide in arterial blood, and pulsus paradoxus. Okay, a mnemonic for this is etiologies of obstructive pulmonary disease: ABCO, asthma, bronchiectasis, COPD, cystic fibrosis, and obstructions like in tracheal or bronchial cases. Okay. Key fact here is beware, all that wheezes is not asthma. Other conditions that can cause wheezing are foreign body inhalation, left heart failure, that's called cardiac wheezing, and COPD, that is anything causing airway constriction. Obstructive versus restrictive lung disease. Test normal, obstructive, and restrictive. So in FEV1 over FVC or FEV 1%, more than 0.7. Normally it's more than 0.7. So in obstructive it decreases, and restrictive it's normal or it's increased. FEV 1% of predicted, it's usually 80% to 120. If it's decreased, again, left is lower, so that's going to be obstructive, and right is going to, if it's lower, it's also restrictive, so that doesn't help. FVC is, again, lower. Functional residual capacity is going to be increased in obstructive, and in restrictive it's decreased. And total lung wall capacity is going to be increased in obstructive and decreased in restrictive. Okay, so we have the lung volumes over here, and key fact is that, am I missing anything? Forced vital capacity. Okay, so asthma should be suspected in children with multiple episodes of croup and upper respiratory tract infections associated with dyspnea. Children with eczema are more likely to develop asthma or allergic rhinitis than those without eczema. This is title, uh, wait, total volume. Okay, so TV, total volume. This is the inspiratory reserve volume, this is expiratory reserve volume, and this is residual. So when you add total volume plus inspiratory reserve volume, you get inspiratory capacity. Similarly, if you add reserve volume and expiratory reserve volume, residual volume and expiratory reserve volume, you get functional residual capacity. VC here is vital capacity and TLC is total lung capacity. Okay, we know this from step 1 already, so moving on. Aspirin, exacerbated respiratory disease. Semter triad has 3 clinical features: asthma, chronic rhinitis, and nasal polyps. Okay, so if you have aspirin, exacerbated respiratory disease. So after taking aspirin, they're going into asthma, chronic rhinosinusitis with nasal polyps, and intolerance to aspirin or NSAIDs. NSAID most commonly upper and lower respiratory tract symptoms, but occasionally also rash, abdominal pain, or vomiting. Pseudo-allergic reactions, that is immunoglobulin E, not mediated by it. Key factor is the physician should suspect impeding respiratory failure in a patient with severe asthma exacerbation and normal or normalizing PaCO2 and pH. Okay. Diagnosis. Best initial test is spirometry, pulmonary function test, PFTs, obstructive pattern that is reversible with short-acting beta-2 agonist subox. Okay, short-acting beta-2 agonist. Forced expiratory volume in, I believe that was albuterol. First expiratory volume in 1 second, or forced vital capacity less than 70%, less than FEV1, normal over less than FVC, increased residual volume and total lung capacity, normal or increased diffusing capacity of the lung for carbon monoxide, DLCO. Okay. Increase in FEV1 more than, so here it makes sense because DLCO, it basically sees, hold on. Okay, all of these numbers are too much for me, so I'm just going to move on. Increase in FEV1 more than 12% and more than 200 ml in FEV1 with SABA, short-acting beta blocker agonist, albuterol. Yep. PFTs are often normal between exacerbations. Okay. I don't want to spend too much time on this because we'll figure it out during UWorld anyways. But this is the best initial test. Okay, spirometry and pulmonary function test. If they ask you what do you see FEV1, FVC is going to be less than 70% for obstructive patterns, right? Because that's what we're doing, obstructive. And anything left of the 70 is going to be obstructive. And when you do a ratio for our normal divided by decreased FVC, okay, or yeah, I don't get this how they're doing that, but there's going to be increase in residual volume. We already learned that over here, right? FRC is going to be increased, and then there is increase, normal or increase. Oh, okay, it's not a fraction. Okay, so they're saying it's either normal or decrease in functional vital capacity. If you got that before me, congratulations. It's morning for me. And it could be normal or increase in diffusion capacity of the lungs for carbon monoxide. So, okay, diffusing capacity is increased for carbon monoxide. Okay. Uh, oh, okay, right. So remember when we did step one, this is the barrier between alveoli and the capillary over here. And DLCO has high diffusion capacity. So when you uh, give them carbon monoxide, it will basically just, even without any resistance, it's just going to transfer into the capillary, right? So in obstructive, what they're saying is that this will happen at 100%. When there's restrictive, for any reason like interstitial lung disease, this membrane gets affected, right? So this thing is going to have a hard time getting through, and that's restrictive for DLCO. That's how we figure out if there's any problem, because if we give 100% DLCO and when we check in the oximeter, not oximeter, but whatever DLCO meter we have, and we only see like 60% on it, then we know if we're giving 100 and we're only seeing 60%, that means there's something wrong over here. And that's how we can figure out if it's a diffusion related, perfusion related, or ventilation related hypoxia or whatever is going on. Okay. I know I said I wouldn't spend time on this too much, but I did, so whatever. Pulmonary function tests are often normal between exacerbation. Methacholine challenge. So tests for bronchial hyperresponsiveness are useful when PFTs are normal but asthma is still suspected. The methacholine challenge is considered positive with more than 20% decrease in FEV1. The test is sensitive but not specific. Okay, so again, methacholine challenges. It tests for bronchial hyperresponsiveness, right? It's useful for PFTs that are normal, but asthma is still suspected. Okay, so for asthma, this is a good way to diagnose the methacholine challenge. The methacholine challenge is considered positive with more than 20% decrease in forced expiratory volume or functional expiratory volume. What was FEV? Forced expiratory volume, right? Okay. The test is sensitive but not specific. And then we have ABG or arterial blood gas, early exacerbation. Our respiratory alkalosis is caused by hyperventilation less than, and there's a decrease in PaCO2 and there's an increase in pH. Okay. Late severe exacerbation impeding respiratory failure. Respiratory muscle fatigue results in respiratory acidosis caused by inability to ventilate. Normalizing PaCO2, normalizing pH, decreased partial pressure of oxygen in arterial blood gas. So all of these things will help you understand the situation. X-ray of the chest, normal appearance to hyperinflation with flattening of the diaphragm. That was emphysema, right? Treatment. In general, avoidance of allergens or any potential triggers. See table this and this for asthma medication and management guidelines. Okay, mnemonic here. We missed a key fact here. Summary of asthma medications. PRN or as needed medications, short-acting bronchodilators, for example, albuterol. And then there are long-acting medications, inhaled corticosteroids, long-acting beta-2 agonists, for example, salmeterol, long-acting muscarinic antagonists, LAMAs, cute, long-acting muscarinic antagonists, or leukotriene antagonists, for example, Montelukast, and PO by mouth, peroral, which is by mouth, is corticosteroids. Okay. Medication for asthma exacerbations, Asthma. A for albuterol, S for steroids, anti-inflammatory, albuterol is bronchodilator. T for theophylline, rarely used bronchodilator due to narrow therapeutic index. H for humidified O2 in hypoxic patients. Magnesium, bronchodilators used in severe exacerbations. Anticholinergics, bronchodilators. Okay. So here in treatment for acute exacerbations, we're going to give O2, SABA, short-acting beta agonists, albuterol is first line, then systemic glucocorticoids. SABA is SABA or ipratropium and magnesium can be used in severe exacerbation. And they told us about that, right? Okay. Ipratropium should not be used alone in asthma treatment. So again, if it's going to the left, it's obstructive. It's true over here as well. This is the normal one. So here, if it's doing that, and the residual capacity or residual volume increases right from here to here, because that's what it is, and that's obstructive pattern as well. If residual volume decreases, so if this is normal and goes here, the residual volume is decreased, right? So that's restrictive. The vital capacity here, it's remains the same, I believe, right? For obstructive pattern, but in restrictive pattern, it decreases. Let me just make sure. For some normal, right? And so it's normal in obstructive and decreased in restrictive. Okay. And total lung capacity increases in obstructive, and in restrictive it decreases. Okay, so from this point to this point it's more than this, so that's obstructive. From this point to this point it's decreased, so it's restrictive, right? Because I'm paranoid like that. This is more than this, and whoops, this is the same. Oh, wait, this is the same as this. I don't know, but it works if they give you a chart like this, and if you just think of it like if it's going to the right, R for restrictive, and if it's going to the left, it's obstructive. Okay, so obstructive and restrictive lung disease. Shown are typical alterations in lung volumes and capacities in restrictive and obstructive disease. Normal flow volume loops shown in center panel. Obstructive lung disease left causes increased residual volume and total lung capacity. Oh, total lung capacity you take from 0. Okay, got it. Makes sense. So if we were to take it from 0 to this is shorter than this, right? Because lung capacity is from 0 to 6, and this only ends at 4. Whereas here, it's going from 0 to 8. All right. Thick lines matter. Obstructive lung disease causes increased reserve volume and total lung capacity due to air trapping. Restrictive lung disease shows a reduction in all lung volumes due to reduced lung expansion. RV, residual volume, TLC is total and vital capacity, and so on. Okay. Common asthma medications and their mechanisms. Okay, so this is going to be important. So if you have been zoned out like me, get back here. B2 agonists, albuterol, short-acting, relaxes bronchial smooth muscles. Beta-2 adrenoceptors. Salmeterol plus inhaled corticosteroids are uh, long-acting or LABA agents for maintenance therapy. So for maintenance, we give salmeterol plus inhaled corticosteroids. Formoterol plus inhaled corticosteroids are used for maintenance and reliever therapy with both short-acting and long-acting effects. So you like bridging the gap that this one doesn't bridge. This is only for long-acting, right? This is for short-acting, but instead of doing 1, 2, and 3, we can do 1 and 2 with formoterol and ICS. Got it. Corticosteroids. Inhaled corticosteroids, first-line treatment for long-term control of asthma. Beclomethasone, prednisone inhibit the synthesis of cytokines. Okay. Muscarinic antagonists, ipratropium, short-acting muscarinic antagonists, SAMA, competitively blocks muscarinic receptors, preventing bronchoconstriction. Tiotropium, long-acting muscarinic antagonists, LAMA. Okay. Ooh, I think I zoned out. Back to corticosteroids, sorry. Inhaled corticosteroid, first-line treatment for long-term control of asthma. Beclomethasone, prednisone. So it inhibits the synthesis of cytokines, yes. Muscarinic, ipratropium. This is short-acting muscarinic antagonist. It competitively blocks muscarinic receptors, preventing bronchoconstriction, yes. Tiotropium, long-acting muscarinic antagonist, LAMA, yes. Okay. So IPRA is short, IP, and TO is long. 3 letters, and this is 2 letters. Methylxanthines, theophylline. What does that do? It causes bronchodilation by inhibiting phosphodiesterases, thereby decreasing CAMP hydrolysis and CAMP levels. Limited usage because of narrow therapeutic toxic index. It can cause cardiotoxicity and neurotoxicity. Okay. So theophylline is toxic. Okay. Cromolyn prevents the release of vasoactive mediators for mast cells, useful for exercise-induced bronchospasms, effective only for maintenance of asthma, not effective during an acute attack. Toxicity is rare. If I believe if this was the one that they don't use as often from step 1, right? It prevents the release of vasoactive mediators from mast cells, useful for exercise-induced bronchospasm. Okay. Okay. Antileukotrienes, Ziloton. So I think there was a question where the person had exacerbation while working out. So they were taking this, but now even with these short-acting, it was still being exacerbated and it wasn't helping. So what do? Instead of this, you give this, because now it's not exercise induced. It wasn't. Well, the vignette didn't say that they were. They just said now the exacerbations were occurring even at rest. So that's why this wouldn't be the answer anymore. It would be this one. Okay. So effective only for the maintenance of asthma, not effective during an acute attack. So that. Antileukotrienes, Ziloton, a 5-lipoxygenase pathway inhibitor. It blocks conversion of arachidonic acid to leukotrienes. Okay. There used to be a nice little chart in step 1. So we have them here now. Just for revision's sake, we'll go through them again. So beta-2 agonists, We went to that. Corticosteroids. So glucocorticoids act here. They don't let the mast cell degranulation happen, right? Chromalin inhibits that as well. We did muscarinic. Glucocorticoid also works here in chronic response. Okay. Anti-leukotrienes, they act on the cis-LT1 receptor, causes mucus secretion, plasma exudation, eosinophil recruitment. So this blocks that. Okay. Theophylline blocks the prostaglandin E and prostaglandin and adenosine. Okay. Beta agonists, they activate the adenyl cyclate, which in turn acts on CMP, increases that, and it causes bronchodilation. The muscarinic antagonists, so tiotropium or ipratropium, they block acetylcholine. So when you block acetylcholine, it acts on bronchial tone, causing bronchoconstriction. So acetylcholine acts on bronchial tone to cause bronchoconstriction. So muscarinic antagonists block that action. Okay. Right. Okay. Right now we're on leukotriene. Right over here. This is the arachidonic one. So leukotriene right here. 5-HPT makes leukotriene and acts on LTB4, increases neutrophil chemotaxis. Okay. So xylitone, 5-lipoxygenase pathway inhibitor, blocks conversion of arachidonic acid to leukotrienes. Okay. So xylitone right here, that blocks this, so you don't get any neutrophil chemotaxis. Okay. Anti-immunoglobulin E, omalizumab, right here. Monoclonal antibody against IgE. Monoclonal antibody against IgE inhibits IgE binding to IgE receptors on mast cells, used in patients with allergic asthma and high baseline immunoglobulin E levels. Anti-interleukin 5 and interleukin 5R. So these are your mepolizumab or rizilizumab. Monoclonal antibody against interleukin 5. Okay, so over here. Which blocks binding of interleukin 5s, resulting in inhibition of eosinophil differentiation and maturation in bone marrow. Refer to this. Anti-interleukin R, 4R. I think that's a new one. Yeah, that's a new one. Dupilumab. Okay. It binds interleukin 4 receptor and inhibits interleukin 4 and interleukin 13 cytokine-induced responses, thus inhibiting release of inflammatory cytokines, chemokines, and immunoglobulin E. Okay, refer to this table. Okay, let's keep those here for now. Key fact: corticosteroids inhaled in a rush can lead to thrush. Right, it causes that oral thrush thing because it reduces immunity in the pharyngeal area, so then you get oral thrush because of that. Okay. Another key fact: adults and adolescents diagnosed with asthma, even mild forms, should use ICS, inhaled corticosteroids, to control airway inflammation, even in mild forms. Okay. Benefits of low dose inhaled corticosteroids include improved lung function and reductions in symptoms, severe exacerbations, mortality, and exercise-induced bronchoconstriction. Okay. The physician should consider intubation in severe cases like sinusitis, inability to maintain respiratory effort, altered mental status, or in patients with a PaCO2 of more than 50 mmHg or PaO2 of less than 50 mmHg. Initiation and adjustment of maintenance therapy. Initiation of treatment is determined by asthma symptom severity at baseline. Therapy may include a combination of controller medications which prevent exacerbations, for example, salmeterol or inhaled corticosteroids, and reliever medications which treat exacerbation acutely, for example, albuterol. Certain medications, formoterol with inhaled corticosteroids, have both controller and reliever effects. So this is superior. Okay. Controller therapy may be stepped up or down in intensity according to patient's need. Okay, so we'll do that one more time. Initiation of the treatment is determined by asthma symptom severity at baseline. Therapy may include a combination of controller medications like salmeterol plus inhaled corticosteroid and reliever medication which treat exacerbation. Okay, so controller medication prevent exacerbation and reliever one treat exacerbation acutely like albuterol. So albuterol is a reliever medication, controller one is this. Certain medications like the controller one have both controller and reliever effects, so it can act as this as well. However, albuterol will not act like a controller medication, right? Controller therapy may be stepped up or down in intensity according to patient's needs. Bronchiectasis, a disease caused by recurrent cycles of infection and inflammation in the bronchioles that leads to fibrosis, remodeling, and permanent dilation of bronchi. Okay, so let's go through this first. Initiation of asthma treatment in adults and adolescents aged 12 plus based on Global Initiative for Asthma guidelines. So preferred track. Step 1, Step 2, Step 3, Step 4, and Step 5. Step 1 is as needed, low dose. So inhale corticosteroids and or formoterol. As step 2, again, as needed, low dose, ICS, formoterol. Step 3 is now low dose maintenance. So now you give inhaled corticosteroids or a Lambda. Lambda was long acting, what was Lambda? Beta agonist, was it? No, that's, yeah. So long acting beta 2 agonists. So that's salmeterol and inhaled corticosteroids. Oh, okay. So it's either you give inhaled corticosteroids or you can give a combination of inhaled corticosteroid and formoterol for low dose maintenance. Okay, so medium and high dose maintenance, ICS and Lambda. So for all of them, you can basically go with the same answer. Step 5, addition of LAMA, which was long-acting muscarinic antagonists, which is tiotropium. Phenotypic assessment with or without anti-immunoglobulin E and anti-interleukin 5, 5R, anti-interleukin 4R. Consideration of high dose inhaled corticosteroid and long-acting beta agonists. Okay, so low dose maintenance is step 3, and medium to high dose maintenance is for step 4, And step 5 is addition of llama. Criteria for initiation of treatment at various steps. Step 1. Symptoms less than 2 times per month. Step 2. Symptoms fewer than 4 to 5 days per month. Step 3 over here is symptoms on most days or on walking more than once a week. And step 4 is symptoms daily or on walking more than once a week with low lung function. Okay. Water break. So step 1 is symptoms less than 2 times per month. Okay. Once or twice a month is low. A two-step. Step 2 is symptoms fewer than 4 to 5 days with or without week. Per week. I'm so lost right now. Okay. Fewer than 4 to 5 days per week. Why is step 2 this? And then symptoms on most days. Walking more than once. Daily or on walking more than once. Okay, got it. So you give low dose maintenance on this 4 to 5 days per week. This was less than 2 times a month. And then it goes on to most days, but not all days, is step 3. And then step 4 is all days. Okay, so all days, most days, fewer days, less days. Okay. So when you start getting it on most days, that's when you go to low dose maintenance. And when you get it daily, that's when you go to medium or high. And then step 5 is you start looking into other possibilities. Okay. When to step up on going treatment. Treatment can be stepped up or down along one track or can be switched between tracks according to an individual patient's needs. Before stepping up or down, the physician should check inhaler technique, patient adherence, and environmental exposures and confirm that symptoms are due to asthma. So what they mean by tracks is alternate track. As an alternative, SABA short-acting beta agonist can be taken as needed as a reliever medication. This can be combined with low-dose inhaled corticosteroids as needed, or low-dose inhaled corticosteroid maintenance therapy can be started, like step 2. Or all other add-on medications are the same as the preferred track. Yes. Okay, so back to bronchiectasis, a disease caused by recurrent cycles of infection and inflammation in the bronchi and bronchioles that eventually lead to fibrosis, remodeling, and permanent dilation of bronchi. So what's the history and physical examination that we see is it presents with chronic productive cough accompanied by frequent bouts of yellow or green sputum production, dyspnea, possible hemoptysis, and halitosis, associated with a history of cystic fibrosis. Pulmonary infections, for example, Pseudomonas atypical mycobacteria, allergic bronchopulmonary aspergillosis, hypersensitivity immunodeficiency, localized airway obstruction, aspiration, autoimmune disease, or inflammatory bowel disease. Right, so all of these, again, one more time. If you get a history of cystic fibrosis, pulmonary infection like Pseudomonas or atypical microbacteria, ABA, um, ABPA, allergic bronchopulmonary aspergillosis, hypersensitivity, immunodeficiency, localized area obstruction, aspiration, autoimmune disease, or inflammatory bowel disease, they can all cause this. Okay. Um, Physical examination reveals rales, wheeze, bronchi, um, purulent mucus, and occasional hemoptysis. Okay, bronchiectasis. CT scan of the chest demonstrates markedly dilated and thick-walled airways, consistent with bronchiectasis in this cystic fibrosis CS patient. Okay, and diagnosis. Chest X-ray shows increase in bronchiovascular markings and tram lines, parallel lines outlining dilated bronchi as a result of peribronchial inflammation and fibrosis. Most accurate test is okay. So chest X-ray is going to show bronchiovascular markings because this is usually how they will show you and test you. So bronchovascular markings and tram lines are seen, so these are parallel lines outlining dilated bronchi as a result of peribronchial inflammation and fibrosis. And the most accurate test is high-resolution CT, dilated airways that is larger than pulmonary arteries, and balloon cysts are seen at the end of the bronchus, mostly lower lobes. You can do spirometry and pulmonary function tests. You'll see an obstructive pattern with a decrease in FEV1 by FVC ratio. So if it's lower, it's left. Additional tests to identify underlying etiologies depends on clinical suspicion. Spectrum microscopy and culture may reveal chronic infection. For example, Pseudomonas aeruginosus, E. coli, tuberculosis, or suggest allergic bronchopulmonary aspergillosis. That is, presence of eosinophil or hyphae. Alpha-1 antitrypsin levels can rule out deficiency. Sweat chloride and or genetic testing for cystic fibrosis, rheumatoid arthritis, and ANA or other screening tests. Rheumatoid factor, ANA, or other screening tests for autoimmune disease may be considered. So, question: a 10-year-old child with a history of asthma on daily fluticasone has been using an albuterol inhaler once a day as needed for several weeks. What changes should be made to the current regime? They can add salmeterol or they can increase the dose of this, but they need to check if it's okay. I'm just going to look at the answer. This child has moderate persistence asthma with daily symptoms. The patient will benefit from an inhaled corticosteroid and a long-acting beta-2 agonist, such as salmeterol, for prevention of symptoms. Yes, long-acting LAMA, because that is step 3 or 4, 3, where you add LABA. Okay. Hold on. So LABA is salmeterol. Okay. Formoterol is short and long acting effect, I guess. Okay. I think I confused the two over here. So formoterol is only up to step 1 and 2. From step 3 and above, you give salmeterol. Okay. All right. And here we are back to treatment. Yes. Over here. Bronchiectasis. CT of the chest demonstrates markedly dilated, thick-walled airways. Okay. Consistent with bronchiectasis in this cystic fibrosis patient. Okay. Treatment for bronchiectasis. Medications. Antibiotics for exacerbations, decreased bacterial load, and airway systemic inflammatory mediators. Empiric therapy is respiratory fluoroquinolone. That's levofloxacin or moxifloxacin. Tailoring of treatment to sputum culture results in available and allergic bronchopulmonary aspergillosis. You give systemic corticosteroids and antifungals like voriconazole and itraconazole. And lifestyle changes, bronchopulmonary hygiene like cough promotion, postural drainage, and chest physiotherapy. Okay, so lifestyle. You can do these. And surgery, consideration of lobectomy for localized disease or lung transplant for severe disease. Okay. COPD, chronic obstructive pulmonary disease, a disease with decreased lung function associated with airflow obstruction, can be divided into two major subtypes: chronic bronchitis or emphysema. Chronic bronchitis is productive cough for more than 3 months per year for 2 consecutive years. This is clinically diagnosed. Emphysema is destruction and dilation of structures distal to the terminal bronchioles. Pathologic diagnosis that may be secondary to smoking, centrilobular, or alpha 1 antitrypsin deficiency, which will cause panlobular. Okay. Key fact here is in patients with COPD and chronic hypercapnia, excess supplemental oxygen can decrease ventilatory drive, resulting in worsening hypercapnia and respiratory acidosis. Another key fact is consider alpha 1 antitrypsin deficiency in patients who is less than 60 years of age and has a family history of COPD, has minimal or no smoking history, has liver disease, and has basilar predominant COPD. Thank you. Another key fact is supplemental O2 and smoking cessations are the only interventions proven to help survival in patients with COPD. So O2 and don't smoke. Kinda common sense there, ain't it? History and physical examination. Symptoms are minimal or non-specific until the disease is advanced. The clinical spectrum is shown in this table. Most patients are a combination of the two phenotypes. Symptoms: classic barrel chest, use of accessory chest muscles, jugular venous distension, and expiratory wheezing, dyspnea on exertion, and muffled breath sounds. And pay attention to these because this is what shows up, right? So symptoms, again, classic barrel chest is what's seen in COPD, and particularly in emphysema, right? Use of accessory chest muscles, jugular vein distension, and expiratory wheezing, dyspnea on exertion, and muffled breath sounds. Okay, muffled breath sounds, COPD. And expiratory wheezing, COPD. Jugular venous distension with the use of accessory chest muscles, COPD. Classic barrel chest, COPD. Muffled breath sounds, COPD. Okay. ABG, air blood gas, or what was ABG? Yeah, air blood gas. All right. Arterial blood gas, sorry. Don't mind me, I'm just waking up. Gram stain and so ABGs. So hypoxemia with acute and chronic respiratory acidosis, increase in PaCO2. Gram stain and sputum culture, considered if bacterial infection is suspected. For example, fever, productive cough, and new infiltrate on chest X-ray. Diagnosis: best initial test, spirometry. Okay. All right. Best initial test. Sorry. Spirometry. PFTs. Obstructive pattern that is non-reversible with short-acting beta agonist or albuterol. Right. So do spirometry, and if you see obstructive pattern in non-reversible, that is non-reversible with SABA, it's COPD. FEV1, FVC, if you already know this one, less than 70. Decrease in forced expiratory volume. Decrease in functional vital capacity, or if it's normal, there's increase in residual volume and TLC. Okay, so if there's increase in RV and TLC, it's COPD. Decrease in these, it's that. There's decrease in TLC for restrictive, right? We'll do that next. So minimal, less than 12% to no changes in FEV1 with SABA. So that's when this kicks in. Less than DLCO, decreased DLCO, sorry. So that's in emphysema. Okay. Because remember, emphysema, there's destruction of the alveolar walls, right? Due to inflammation from smoking. So the cytokines come in, neutrophils, they attack the inflammatory stuff, and then the wall is like collateral damage. Okay, late stage COPD, normal DLCO and chronic bronchitis. So decreased DLCO in emphysema or late stage COPD, but normal DLCO in chronic bronchitis. Okay, so this table is for COPD subtypes, emphysema and chronic bronchitis. How do you differ between the two? Emphysemas are known as pink puffers, terminal airway destruction and dilation. Appearance: thin, wasted appearance and pursed lips, minimal cough. Acid-base status is late hypercarbia, hypoxia, and pink. Chronic bronchitis, blue bloaters. Definition is productive cough more than 3 months for 2 years. Appearance is overweight and edematous. And acid-base status is going to be early hypercarbia and hypoxia, hence blue. Okay. Let me make sense of that. Give me a second. Emphysema, destruction, but carbon dioxide are very slippery, so they can slip through, so you're not going to get hypercarbia. But oxygen has a hard time getting through, so that's why you get hypoxia. In chronic bronchitis, cough is going to block the gas movement of carbon dioxide out from the capillary into the alveoli, and that's why you get early hypercarbia, and hypoxia is going to be there because of the same reason. Appearance is going to be overweight and edematous. Okay. You see cyanosis because of this. Okay. Productive cough more than 3 months for 2 years. Terminal airway destruction and dilation. Thin. So pink puffers are thin, wasted appearance, and pursed lips because they're trying to make a negative pressure in the alveoli. So that's why they have pursed lips, to open it up, because elasticity is gone, right? So this is the only way they can make it, how you say, like blow the bubble, right? Minimal cough. Okay. Did that. And COPD treatment. Okay. Acute exacerbation, some supplemental O2, titrate, saturation of peripheral oxygen, titrate O2, saturation to 88% to 92%. This is going to be, this is not the image in the book, it's just the PDF is not doing a good job of remembering what the picture was. Okay. Acute exacerbation, supplemental O2, titrate, saturation of peripheral oxygen, titrate O2 saturation to 88% to 92%. Okay. So that's the goal to get to. Inhaled bronchodilators, SABA or anticholinergics, ipratropium, systemic corticosteroids, prednisone, addition of antibiotics if two or more cardinal symptoms, increase in dyspnea, increase in cough, sputum production, change of from baseline, severe exacerbations, respiratory failure, severe hypoxemia, and respiratory acidosis, altered mental status. Again, non-invasive positive pressure ventilation with bilevel BiPAP first. Note increased secretions, facial trauma, burns, poor mass yield, risk of aspiration, for example, due to altered mental status, are contraindicated in non-invasive positive pressure ventilation. If non-invasive positive pressure ventilation fails, next step is endotracheal intubation. For chronic COPD, it's lifestyle modification, smoking cessation, give vaccines, pneumococcal vaccine, influenza vaccine. This is the 23 one. Polysaccharide PPSV23. We give PCV 13, 15, 20, which are conjugate. Okay, so when do we give which? If it's someone 19 to 64 years of age, we give PCV 20 alone, or we can give PCV 15 plus PPSV 23. If it's someone more than 65 years of age, we give PCV 20 alone, or PCV 15 plus PPSV 23. Okay. Corporate wants you to find the difference between these. They're the same picture. All ages. Influenza vaccine annually. Inhaled bronchodilators, SABA, albuterol, LABA, salmeterol, anticholinergics, ipratropium, tiotropium. If two or more exacerbations per year, consider for adding inhaled corticosteroids, long-term oxygen therapy. Okay, so we vaccinate them, we tell them to stop smoking. What do we give them on prescription? We give them inhaled bronchodilators, so salbuterol, salmeterol, or anticholinergics like ipratropium or tiotropium. If two or more exacerbations are still happening, consider adding inhaled corticosteroids or long-term oxygen therapy. This is for chronic COPD. Okay. Long-term oxygen therapy is indicated if saturation of oxygen, saturated partial oxygen is less than 88%, okay, or PO2 partial arterial oxygen is less than or equal to 55 mmHg, okay, in most patients. In those with cor pulmonale, right heart failure, or polycythemia where hematocrit is more than 55%, long-term oxygen therapy is indicated when SpO2 is less than 89% or PaO2 is less than or equal to 59 mmHg. Okay. Supplemental O2 can worsen hypercapnia. Okay. Why? Because it can cause shunting, right? Vasoconstrict the parts that are not functional, and that will worsen hypercapnia, I guess. The goal oxygen saturation is 90 to 93% here. So with this one, the goal was 88 to 92% for acute exacerbation. For chronic COPD, it's 90 to 93. Here, the photo was of COPD post posterior anterior PA and lateral diaphragm of a patient with emphysema. Shows hyperinflation with the large lung volume, flattening of the diaphragm, and minimal peripheral vascular markings. Okay, key fact here is treatment for acute asthma and COPD exacerbation both involve beta-2 agonists and corticosteroids. During an acute COPD exacerbation, antibiotics may also be given. During an acute asthma exacerbation, magnesium can be given. Okay, so acute, magnesium can be given. During an acute COPD exacerbation, antibiotics may also be given. Okay. Here, chest x-ray is okay. Chest x-ray is going to show hyperinflated lungs, decreased lung markings with flat diaphragm, and a thin appearing heart. And mediastinum are sometimes seen. Parenchymal bulla and subpleural plebs are also seen. Okay, and see figure this. Treatment, table 214.5. This one right here. Let's do that. So, all patients, first thing you do, smoking cessation, pneumococcal vaccine, then pneumococcal vaccine, 19 to 64 years of age, you give PCV alone, or you give PCV 15 and PPSV 23. If they're more than 65 years of age, you give PCV 20 alone, or PCV 15 plus PPSV 23. It's like a deja vu, man. Reading the same thing over and over again. Influenza vaccine. I'm sure they did this because there's some kind of significance, but I cannot spot it. If you can spot it, comment down below. Influenza vaccine, if chronic hypoxemia, oxygen therapy, pulmonary rehabilitation. Okay, so management by patient group. Less than one exacerbation with no hospital admission, it's either mild. If CAT, which is COPD assessment test, is less than 10, they're considered Group A. In Group A, we give short-acting or SABA or SAMA. Okay, less than 1 with no hospital admission. So less than 10, CAT. If it's less than 1 and CAT came out to be more than 10, it's considered severe. Then we give them Group B medication, which is SABA as needed, plus long-acting bronchodilators, LABA or LAMA. Okay, that's long-acting beta agonists and long-acting muscarinic antagonists. Sorry. If management by patient group is right, so if they're having exacerbation more than two or more, and one or more of those times are with hospital admission, we can consider them for mild and severe if the CAT is less than mild, and if severe then more than 10, then it's going to be Group C and D. In Group C, for the mild ones where there is hospital admission or more than 2 exacerbations, you give short-acting beta agonists per as needed, plus long-acting muscarinic antagonists. Okay. Okay, so okay, got it. There's like slight similarities, but they're not similar. And then there's group D for severe cases, Savopirin plus long-acting muscarinic antagonists. Okay, so albuterol as needed plus long-acting that, but so that's similar to this so far. So what's the difference? If severe symptoms, CAT is more than 20, LAMA or LABA. If overlapping asthma, then LABA and inhaled corticosteroid is given. Okay. So if severe symptoms, again, CAT more than 10 and more than twice a year exacerbations, then LAMA and LABA can be considered. And if overlapping asthma, then give LABA with salmeterol and inhaled corticosteroids. Drink water. Actually, let's take a break here. All right. Interstitial lung disease. It is a heterogeneous group of disorders characterized by inflammation and or fibrosis of the interstitium. In advanced disease, cystic spaces can develop in the lung periphery. A development that leads to the characteristic honeycomb pattern seen on CT. Interstitial lung disease is also called diffuse parenchymal lung disease. So mnemonic here is etiology of restrictive lung disease if the lungs ain't compliant. Ain't, A for alveolar, edema, hemorrhage, or pus. I for interstitial lung disease, idiopathic. Pulmonary fibrosis, usual interstitial pneumonia, non-specific interstitial pneumonia, chronic hypersensitivity pneumonitis, sarcoidosis, and with interstitial pneumonia. And for neuromuscular myasthenia, phrenic nerve palsy, myopathy, okay, and thoracic wall, kyphoscoliosis, obesity, ascites, pregnancy, ankylosing spondylitis. Okay. So subgroup of interstitial lung disease are exposure related, as in asbestosis, silicosis, berylosis, coal workers, pneumoconiosis, medications, for example, amiodarone and bleomycin, hypersensitivity, pneumonitis, radiation-induced injury, interstitial lung disease associated with systemic disease or connective tissue disease like polymyositis, dermatomyositis, sarcoidosis, amyloidosis, vasculitis, scleroderma, like Crest syndrome, or it could be idiopathic pulmonary fibrosis, cryptogenic organizing pneumonia, acute interstitial pneumonia. Here, a key fact is medication and interventions that can cause or contribute to interstitial lung disease include amiodarone, busulfan, nitrofurantoin, bleomycin, methotrexate, radiation, and long-term high O2 concentration, for example, ventilators. Okay. History and physical examination you see is it presents with shallow, rapid breathing, progressive, deep with exertion, and a chronic, non-productive cough. May have cyanosis, inspiratory squeaks, fine or Velcro-like crackles, clubbing, or right heart failure. Diagnosis. Okay, again. So it presents with shallow, deep breathing, right? Progressive dyspnea with exertion and a chronic non-productive cough. So deep breathing, shallow is ILD, and in the other one it was what was it? Shallow, rapid. Sorry, not deep breathing. That's why it doesn't make sense. Okay, I read that wrong. It presents with shallow and rapid breathing. Progressive dyspnea with exertion and a chronic non-productive cough. May have cyanosis, inspiratory squeaks, fine or Velcro like crackles, clubbing, or right heart failure. So clubbing, not many things do clubbing, so if there's clubbing, we can think of this, or I believe bronchiectasis is also one that causes clubbing. Diagnosis, best initial test, chest x-ray, reticular, nodular, or ground glass pattern. Next, best step is if chest x-ray is suspicious for interstitial lung disease, then high resolution CT. CT shows honeycomb pattern in severe disease. Okay. Pulmonary function test. Restrictive patterns are either they're normal or increase in FEV1 FVC ratio, right? And if it goes to the right, it's restrictive. So that decrease in FVC, that's functional vital capacity. There's restriction because you can't inflate the lungs fully, so obviously there's a decrease in forced expiratory volume. Again, the chest wall is not pushing in the alveoli, so it has a nope. Sorry, wrong. Decrease in forced expiratory volume because it wasn't expanded as much, so there wasn't that much air to begin with. So there's less air to begin with, so less air will come out. Decrease in total lung capacity because of the chest wall not allowing the lungs to expand. And decrease in FVC and decrease in DLCO. DLCO because there is damage to the membrane. If systemic disease is suspected as the cause, the physician can consider serologic testing. For example, ANA anti. Give me a second here. Just gotta make a note. Okay, sorry about that. Back to this. If systemic disease is suspected as the cause, the physician can consider serologic testing. For example, anti-neutral ANA, anticyclic citrulinated peptide, creatine kinase, aldolase, anti-Jo1, anti-neutrophil cytoplasmic antibody, ANCA, anti-tropioisomerase, anti-double-stranded DNA. Okay. So, do them. Most accurate test is surgical biopsy. This is not recommended if CT findings are characteristic. If IPF and rheumatologic disease, a surgical biopsy is only performed when the diagnosis is uncertain. Treatment. Supportive. Avoidance of exposure to causative agents, medications, anti-inflammatory immunosuppressive agents for some disease, for example, corticosteroids, antifibrotic agents, pirfenidone, nintedanib. For IPF, surgery referral for lung transplantation indicated at late stages of IPF. Okay. I'm trying to figure out what IPF was. They're just throwing these short forms at me like I know these, or I should know these. Oh, idiopathic pulmonary fibrosis. Okay. Got it. We're solving these. Okay, so idiopathic pulmonary fibrosis chest CT showing the characteristic honeycomb lung that is seen in advanced disease. Uh, Lung biopsy specimen demonstrating increased interstitial fibrosis and nonspecific inflammation and alveolar thickening. Okay, give me a second. Okay, on to cryptogenic organizing pneumonia. Cryptogenic organizing pneumonia is a form of diffuse um, interstitial lung disease. Cryptogenic refers to the idiopathic nature of the condition. Organizing pneumonia refers to the typical pathologic appearance of the condition wherein buds of the granulation tissue form in distal air spaces. Alveoli and bronchial lumens, bronchiolitis or obliterans. These findings are not specific to a disease, but just in the type of inflammatory process. History and physical examination typically presents with subacute fever, dry cough, shortness of breath, weight loss, anorexia, and malaise that have failed to respond to antibiotic therapy. Diagnosis. Other causes such as infection. So again, this is very vague stuff. Subacute fever, dry cough, shortness of breath, weight loss, anorexia, and malaise that have failed to respond to antibiotic therapy. So that's when you start thinking of cryptogenic organizing pneumonia. Okay, wherein granulation tissue form in distal air spaces, alveoli, and bronchial lumen called bronchiolitis obliterans. These findings are not specific to disease, but just a type of inflammatory process. I remember seeing that in transplant rejection for lungs, right? Okay. So diagnosis. Other causes such as infection and autoimmune disease must be excluded. Radiographic findings of chest, X-ray, or CT include bilateral peripheral patchy opacities that may migrate. Pulmonary function tests show a restrictive defect with diffusion impairment. Pathologic examination of biopsy specimens is diagnostic. Generally, surgical biopsy is preferred, although transbronchial biopsy can be attempted. Okay, here just CTs showing characteristic honeycomb lung that is seen in advanced disease, lung biopsy specimen demonstrating increased interstitial fibrosis and nonspecific inflammation with alveolar thickening. Okay. Treatment here is treatment with corticosteroids results in dramatic clinical and radiologic response. Relapse is common on tapering steroids. Okay, so you gotta pay attention to or monitor the patient, I guess, or have follow-ups to make sure that you're keeping this in check. Overall prognosis is excellent. Okay, done with those. I did not like that bit at all. Too much physio to remember. Okay, on to systemic sarcoidosis, a multi-system disease of unknown etiology characterized by infiltration of non-caseating granulomas. In the United States, more commonly found in females, although it can occur in males too, of African or Northern European descent. Most often arises in the third or fourth decade of life. Question. A 25-year-old black woman presents to the physician's office with painful bumps on her shins, weight loss, and cough. Examination reveals a prominent 1 centimeter right axillary lymph node. What is the next best step for diagnosis? Answer. This is presumed sarcoidosis. Biopsy of the right axillary lymph node is the next best step for diagnosis and is less invasive than transbronchial lung biopsy. Okay, so history and presentation. Systemic sarcoidosis can present with fever, cough, dyspnea, malaise, weight loss, or arthritis. Love-Green syndrome, erythema nodosum, bilateral hilar adenopathy, migratory polyarthralgia, and fever, associated with good prognosis. Extrapulmonary manifestations can involve the following organs: liver, eyes, skin, central nervous system, heart, and kidneys. Uveitis, erythema nodosum, violaceous skin plaques, CNS, third degree heart block, arrhythmias. Diagnosis. Best initial test is chest x-ray shows bilateral hilar adenopathy and reticular opacities. Upper lobe predominant. Figure illustrates what does it illustrate? Bilateral hilar lymph nodes. You can see the arrows there in patients with pulmonary sarcoidosis. Okay. So illustrates chest x-ray findings of sarcoidosis. High resolution CT is usually done following suspicious chest x-ray. High resolution CT. Next best step is if chest x-ray CT is suspicious, then bronchoscopy biopsy. Non-caseating granulomas are diagnostic in the presence of a compatible clinical picture with exclusion of other diseases. Did I miss any keynotes, key facts? No, just here. Okay. Non-caseating granulomas are diagnostic in the presence of compatible clinical picture with exclusion of other diseases. PFTs restrict the pattern with decrease in DLCO. Other findings are increase in serum angiotensin converting enzyme ACE levels, neither sensitive nor specific. There will be hypercalcemia, hypercalciuria, increase in alkaline phosphatase, and with liver involvement, lymphopenia, cranial nerve defects, and arrhythmias. Okay. Treatment here is if they're asymptomatic, just observation. If symptomatic, then systemic glucocorticoids indicated for deteriorating respiratory function, constitutional symptoms like and hypercalcemia and extrathoracic organ involvement. So, steroids. Refractory disease. Immunosuppressants, for example, methotrexate, azathioprine, TNF-alpha inhibitors, Love-Green syndrome, NSAIDs, and supportive therapy. Mnemonic. Learning the features of sarcoid can be grueling. G. Granulomas, arthritis, uveitis, erythema nodosum, lymphadenopathy, particularly hilar and seen on chest x-ray, interstitial fibrosis, negative tuberculosis test, and gamma globulinemia. Okay. Okay. Hypersensitivity, pneumonitis. Here are key facts before we do that. Love-Green syndrome is a type of sarcoidosis with the following triad. So arthritis, erythema nodosum, and bilateral hilar adenopathy, associated with good prognosis. Water break. Drink water. Right. I can't hear you if you said no to drinking water. Why would you say no? Drink it. It's right there. Okay. Hypersensitive pneumonitis. Alveolar thickening and non-caseating granulomas secondary to environmental exposure. For example, farmer's lung, seen in farmers and cattle workers due to chronic inhalation of mold that grows on hay and grain, or pigeon breeders' disease due to chronic inhalation of particles from feathers or bird droppings. So feathers, hay, you know, think of hypersensitive pneumonitis. So what happens is alveolar thickening and non-casing granuloma secondary to environmental exposure. History and PE. In acute, you see dyspnea, fever, malaise, shivering, and cough starting 4 to 6 hours after exposure. The physician should gather a job, travel history to determine exposure. Okay, so it can be 4 to 6 hours after exposure that you start seeing dyspnea, fever, malaise, shivering, and cough. So get their job and travel history to determine exposure. In chronic, presents with progressive dyspnea. Physical examination reveals fine bilateral rails. Diagnosis here is appearance on chest X-ray CT is variable, but upper lobe fibrosis is common feature for chronic disease. Treatment is the patient should avoid ongoing exposure to inciting agents. The physician should prescribe corticosteroids to decrease chronic inflammation. Again, steroids. Pneumoconiosis. Pneumoconiosis refers to lung conditions caused by inhalation of organic or non-organic airborne dust and fibers. Risk factors include prolonged current occupational exposure and inhalation of small inorganic dust particles. So remember these from step 1. Disorder, asbestosis, co-workers disease, silicosis, and berylosis. Asbestosis. Trying my best here, okay? Don't be harsh. History. Work involving the manufacture of tile or brake linings, insulation, construction, demolition, or shipbuilding. Again, so in tile or brake lining, insulation, construction, demolition, or shipbuilding. Asbestosis presents 15 to 20 years after initial exposure. Imaging findings: linear opacities at lung bases and interstitial fibrosis, calcified pleural plaques. Image A, indicative of benign pleural disease. Image B shows ferruginous bodies and alveolar sputum. Remember those? Step 1 book had a really nice image for that one, but you'll see like a pink little thing, hair-like stuff, right? Okay, so again, you can probably figure this out just from the history, but linear opacities at lung base and lung base, right? So these things right here, the plebs that you're seeing right there at the edges, those are dead giveaway for asbestosis. So linear opacities at lung base and interstitial fibrosis, calcified pleural plaques, that's what those are, indicative of benign pleural disease. Image B shows ferruginous bodies and alveolar sputum. Complications: increased risk for mesothelioma, which is rare, and lung cancer. The risk for lung cancer is higher in smokers. The most common malignancy associated with asbestosis exposure is bronchogenic carcinoma. Okay, so what's the future in these patients with asbestosis? Mesothelioma, which is rare, and lung cancer. Okay, and the risk of lung cancer is higher in smokers. The most common malignancy associated with asbestos exposure is bronchogenic carcinoma. Coal workers' disease and work in underground coal mines. Okay, sorry, I was just trying to remember that coal workers' disease happens in people who work underground in coal mines. Image findings: small nodular opacities less than 1 centimeter in upper lung zones. Okay, so cold down under, it affects the upper lung lobes. Most of these are like this, right? If you find it on the ground, it's going to affect the upper lobes. If you find it in air, it's going to affect the lower lobes, right? Or air or ceiling, then it affects the lower lobes. Okay, so that's why this is at lung basis. This is at upper lung lobes. Progressive massive fibrosis is the complication. Silicosis, work in mines or quarries, or with glass, pottery, or silica. Small, less than 1 centimeter nodular opacities in upper lung zone, eggshells, calcification. This was a buzzword in step 1 for silicosis, eggshell calcification. Okay, so again, work in mines, pottery, or silica. This is all like quarries. It's down on the ground, so it's going to affect the upper lung zones. Increase in risk for TB, need annual TB test, progressive massive fibrosis. Berylosis, work in high technology fields such as aerospace, nuclear and electronic plants, ceramic industries, foundries, plating facilities, dental material sites, or dye manufacturing. What will you see? You will see diffuse infiltrates and hilar adenopathy. It requires chronic, and the complications, it requires chronic corticosteroid treatment. Okay. Spirometry. Okay, consistent with restrictive disease. What is this related to? I don't know. I don't see the A anywhere, but anyways. History. PE diagnosis outlines the finding and diagnostic criteria associated with common pneumoconiosis. Treatment is avoidance or trigger, supportive therapy, and supplemental oxygen. Eosinophilic pulmonary syndromes. It's a diverse group of disorders characterized by eosinophilic pulmonary infiltrates and abnormal peripheral blood. Sorry. Let me just fix my screen. Okay. A diverse group of disorders characterized by eosinophilic pulmonary infiltrates and abnormal peripheral blood eosinophilia includes ABPA, Loeffler syndrome, acute and chronic eosinophilic pneumonia, eosinophilic granulomatous matosis, polyangiitis, and drug-induced disorders, for example, NSAIDs, nitrofurantoin, or sulfonamides. Again, a person with, lung symptoms, pulmonary symptoms, and then you check their lab values and you see eosinophils are increased, start thinking about ABPA, Loeffler syndrome, acute and chronic eosinophilic pneumonia, or eosinophilic granulomatosis polyangiitis, or it could be drug-induced if they're taking NSAIDs, nitrofurantoin, or sulfonamides. Okie dokie. History PE. Presents with dyspnea, cough, potential blood tinge sputum, and or fever. Key fact here is Loeffler syndrome is a form of eosinophilic pulmonary disease characterized by absent or mild respiratory symptoms. Most often dry cough, fleeting migratory pulmonary opacities, and peripheral blood eosinophilia. Diagnosis: complete blood cell count, CBC, may reveal peripheral eosinophilia, more than 500 eosinophils. Okay. Chest X-ray shows pulmonary infiltrates. Bronchoalveolar lavage, increase in eosinophils are seen, more than 25%. Okay, so you do CBC, it may reveal peripheral eosinophilia. Chest X-ray, it will show pulmonary infiltrates. Bronchoalveolar lavage, increase in eosinophils. Treatment: removal. So again, blood tinge sputum, cough, dyspnea with eosinophils is eosinophilic pulmonary syndrome. Okay. Treatment: removal of extrinsic cause or treatment of underlying infection, for example, helminths, if identified. Corticosteroid treatment may be used, again, steroids. Allergic bronchopulmonary aspergillosis. ABPA is a hypersensitivity reaction of airways to colonization by Aspergillus. As a result of recurrent inflammation, obstruction, and mucus secretions, bronchiectasis and and fibrosis develop. Early treatment may prevent progression to bronchiectasis or pulmonary fibrosis. Okay, once more. ABPA is a hypersensitivity reaction of airways to colonization by Aspergillus as a result of recurrent inflammation, obstruction, and mucus secretions. Bronchiectasis and fibrosis develop. Early treatment may prevent progression to bronchiectasis or pulmonary fibrosis. History and physical examination. Patients often have underlying asthma or CF, cystic fibrosis. Okay. And they present with recurrent fever, bronchial obstruction, brownish expectoration, and hemoptysis. Okay. Diagnosis. Initial tests look for evidence of Aspergillus sensitization. For example, Aspergillus specific immunoglobulin E antibodies or positive Aspergillus skin prick test. Negative results rule out aspergillosis. Okay, so initial tests, this is how you diagnose it. Look for evidence of Aspergillus sensitization. So Aspergillus specific IgE antibodies is what you're going to look for. Or positive Aspergillus skin prick test. So either or. Negative results rule out aspergillosis. Okay, so there are no false negatives. Patients sensitized to Aspergillus should undergo further lab testing for total serum immunoglobulin E. Aspergillus precipitants and eosinophil counts generally more than 500 cells per microliter. Sputum may have eosinophil-rich plugs and charcoal-in crystals. Okay, that seems important. So, sputum may have eosinophil-rich plugs and charcoal-in crystals. Culture of sputum may grow Aspergillus. Imaging with CT or chest X-ray may show evidence of bronchiectasis. Okay. Notice how they didn't talk about any type of cavitation here in the chest X-ray findings. Treatment. Systemic glucocorticoids, prednisone, and antifungal therapy. Itraconazole or voriconazole may be used. Optimization of asthma treatment with possible addition of biologic agents, for example, omalizumab. Patients with CF may also benefit from omalizumab. Patients should reduce Aspergillus exposure at work or home. Complications include acute chronic invasive pulmonary aspergillosis and aspergilloma. Excuse me. Acute respiratory failure. Okay. Something new. We're back to physio. Hypoxemia is below normal arterial oxygen level, normally defined as PaO2, less than 60 mmHg. Causes include ventilation perfusion mismatch, right to left shunt, hypoventilation, low inspired O2 content, like high altitudes, and diffusion impairment. Okay, so all of these can cause hypoxemia, which is below normal arterial oxygen levels. History of our physical examination findings depend on the etiology: decreased saturation of peripheral oxygen, cyanosis, tachypnea, shortness of breath, pleuritic chest pain caused by wheezing, coughing, and altered mental status may be seen. Diagnosis: best initial test, ABGs. Exhibition of decrease in PO2. Calculate the alveolar arterial oxygen gradient. 150 minus the PaCO2 divided by 0.28 minus the partial pressure of oxygen. Okay, so do that to figure out the hypoxemia, if it's hypoxemia or not, right? Note, presume atmospheric pressure is 760 mmHg at sea level. Fraction of inspired oxygen is at 0.21. Chest X-ray to evaluate for infiltrative process, for example, pneumonia. Atelectasis, a large pleural effusion or pneumothorax, and to assess for acute respiratory distress syndrome. An increase in AA gradient suggests shunt. VQ mismatch or diffusion impairment. This figure summarizes the approach towards patients who have hypoxemia. Treatment here is address the underlying etiology and administer O2 before initiating evaluation. Key fact: if the problem is hypoventilation or low inspired oxygen, the AA gradient will be normal. If the problem is ventilation perfusion mismatch or shunting, the AA gradient will increase. Okay. The AA gradient is alveolar and arterial oxygen, right? So I'm just trying to think. I'm just going to be thinking out loud now. So alveolar, arterial. This is alveolar. This is arterial. Okay. So O2, this will be our O2 and O2. So ventilation and constant flow of arteries is going to be down here. Okay, so O2 in ventilation is 1, and this is going to be 1 at physiological, like center lobes, right? So it's going to be 1. So if this increases, that means the VQ mismatch is increased. So if we have more over here but less over here, right, that means VQ mismatch is increased. So an increase in AA gradient suggests shunt. So VQ mismatch. Okay. Okay. Right, and physiologically, VQ ratio is in a lung, physiological lung, is 1 in the center. There's more ventilation up here, and so there's increase up here, and here there's dead space, a lot more in the lower lobes. So more perfusion is there, right? The Q is perfusion, so more perfusion is here, but less ventilation is down here. So there's decrease down here. Now physiologically, okay. So when there is VQ mismatch, that's when we try to figure all of this out, okay. So now that that's cleared, we can go on to this. Check, so hypoxemia, you check AA gradient. If it's normal, is PaCO2 increased? If no, then check for, what was FiO2? Fraction of inspired oxygen. For example, decrease in fraction of inspired oxygen, so high altitude, right? Okay. Is PaCO2 increased? If yes, then it could be because of hypoventilation that you're getting hypoxemia, because there's more oxygen in air and then it's getting pushed out. And yeah, okay. Decrease in respiratory drive, neuromuscular disease, myasthenia gravis, and so on. CNS, depression, or obesity, hypoventilation. Okay, so all of these will cause hypoventilation. So you will have increased carbon dioxide. So that's how you know, because carbon dioxide actually leaves the lungs faster than oxygen can enter the lungs, right? So if you have buildup of CO2, that means there's something wrong, like it's not being pushed out, because we know that there's nothing wrong with the membrane because AA gradient is normal. All right. Okay. So if AA gradient is increased, okay, so there is more up here, but not down here. This is the artery again, capillary, and this is the alveoli. So if it's increased, then rule out a second process. Like, is there CO2 increased? Yes. Then it could be because of, again, hypoventilation. Or is PaO2 correctable with oxygen? So now you're giving 100% oxygen here. And if it's correctable, then there's a VQ mismatch. Okay, so because with shunt and 100%, it actually gets it closer to 1, right? VQ mismatch. So as airway disease, asthma, COPD, interstitial lung disease, alveolar disease, atelectasis, pneumonia, pulmonary edema, pulmonary vascular disease. Okay. If it's not correctable with O2, then there's shunt right to left. So intracardiac shunt or vascular shunt with lungs. Within the lungs. Okay. I got that backwards. So 100% oxygen. If it doesn't correct O2, then it's shunt. And if it does correct it, it's because of one of these things. Airway disease like asthma, COPD, interstitial lung disease, alveolar disease like atelectasis, pneumonia, pulmonary edema, pulmonary vascular disease. Okay. Drink water. Water break. Okay, moving on. So hopefully we'll remember that when we do it. So one more time, let's recap it. So hypoxemia, we check AA gradient. If it's normal, we check CO2. If it's hypoxia, we check AA gradient, and if it's increased, then we check if O2, given O2 will improve the PaO2. If it does, then VQ mismatch. If it doesn't, then it's shunt. In PaCO2, if it's increased, it's hypoventilation. If it's not increased, then it's decrease in whatever. Keep forgetting. Fraction of inspired oxygen, right? Sorry. No. Okay, so treatment. Address the underlying etiology. Administer O2 before initiating evaluation. Increase oxygenation parameters if the patient is on mechanical ventilation. See table this. Okay. 12.4, where that at? What's this 12.4? 7. Okay. I see 6. I see 8. Oh, that's figure. Okay. My bad. That's table. Okay. So increase oxygen parameters if the patient is on mechanical ventilation. See this table. Okay. And hypercapnic patient, increase ventilation, increase respiratory rate, or increase vital VT. Ventilation time, sorry, right, I think. I'm sure I'm skipping on these terms. There are too many short forms that my brain is not able to catch up on. So if they have more amount of carbon dioxide in their body, we want to get it out, so we're going to increase ventilation. So increase RR or VT to increase CO2 exchange. Okay, mechanical ventilator parameters affecting oxygenation and ventilation, increase in oxygen and increase in ventilation. So increase in oxygen to increase FiO2, fractional inspiratory oxygen, increase positive and expiratory pressure, PEP. To increase ventilation, we do that so that by increasing RR and increasing VT. Okay. Acute respiratory distress syndrome. Respiratory failure with respiratory hypoxemia, decrease in lung compliance, and non-cardiogenic pulmonary edema with a PO2 FiO2 less than ratio less than 300 or equal to 300. Okay. So respi failure with refractory hypoxemia, decrease in lung compliance, and non-cardiogenic pulmonary edema. Pathogenesis is thought to be dependent on endothelial injury. Common triggers are as follows: sepsis, severe pulmonary infection, aspiration, blood transfusion, inhaled or ingested toxins, drowning, or trauma. I think pancreatitis is also one of these. Overall mortality is 30% to 40%. History and physical examination. Presents with acute onset 12 to 48 hours. Okay. Tachypnea, dyspnea, and tachycardia with or without fever. Cyanosis, labored breathing, diffuse high-pitched rales, and hypoxemia in the setting of one of the systemic inflammatory causes or exposure. Additional findings are as follows. Phase 1 is going to be acute injury. Normal physical examination, possible respiratory alkalosis. Alkalosis because there is low amount of respiratory carbon dioxide in the body, right? Because there's hyperventilation. Phase 2, 6 to 48 hours, hyperventilation, hypocapnia, widening AA gradient. Right? So there's more oxygen in the air than arteries. Phase 3, acute respiratory failure, tachypnea, dyspnea, decrease in lung compliance, scattered drills, diffuse chest opacities on chest x-ray. Phase 4, severe hypoxemia, unresponsive to therapy, increase in intrapulmonary shunting, metabolic and respiratory acidosis. Diagnosis. The criteria for an ARDS diagnosis according to Berlin definition are as follows. Before we do that, AP is just showing diffuse alveolar filling pattern secondary to ARDS. Just gonna go look at that for a sec. Okay, so it basically looks like there is a lot of diffused opacities over here and here in this diagram. So right there and there, those are opacities right there and there. Okay, that's what that shows. And this is pulmonary contusion, rib fractures, subcutaneous emphysema, and lung opacities on right corresponding to the lung contusion, pneumothorax of left lung. Yeah. Okay. Diagnosis. The criteria for an ARDS diagnosis according to Berlin definition are as follows. Acute onset less than 1 week of respiratory distress. Chest x-ray. Bilateral alveolar opacities consistent with pulmonary edema. Pulmonary edema on chest x-ray less than 24 hours after trauma may suggest pulmonary contusion instead of ARDS. Features of pulmonary contusions are shown in this figure. Okay, a PO2 FiO2 ratio is less than 300 and positive and expiratory pressure, continuous positive airway pressure CPAP more than 5 centimeter H2O. Respiratory failure not completely explained by heart failure. Treatment. Treat the underlying disease and maintain adequate perfusion to prevent and organ damage. Prone positioning in select patients with severe ARDS, for example, severe ARDS with PaO2, FiO2 ratio less than 150 mmHg and F fraction inspired oxygen more than 0.6 or PEP more than 5 centimeter of H2O. So basically everything that's here, you try to fix that, right? Use mechanical ventilation with low tidal volume. Right. Now 6 cc. Oh, okay, so VT was tidal volume. Right here. Right. Use mechanical ventilation with low tidal volume, 6 cc per kg of ideal body weight to minimize ventilator-induced lung injury by over-distension of alveoli. Use PEEP to recruit collapsed alveoli and titrate PEEP and FiO2 to achieve adequate oxygenation. To increase PO2, increase PEEP. That's why we do this. FiO2 and PEP increases oxygenation. And increase in RR, increase in VT will cause ventilation increase. Okay. And keep FiO2 less than 60% or 0.6 if possible to prevent oxygen toxicity. Okay, so less than 0.6. So in prone positioning in select patients with severe ARDS with this ratio or this and this. Okay, so you ask them to turn around and face down. Wait, no. Supine, you see the pine trees. So prone is down, yes. So you ask them to lay down and on their tummy. For patients who have this ratio, FiO2 is more than 0.6 and if PEP is already more than 5 centimeters. So try that out. Okay. Goal oxygenation is PaO2 more than 55 mm Hg or SpO2 is more than 88%. Okay. Extubation may be attempted if the cause of respiratory failure has improved, ventilator support required is minimal, low PEP, low positive pressure. Oxygen supplementation is easily accomplished without the support of PEP or other adjuvant treatments, and patient passes a spontaneous breathing trial. Okay. I'm going to take a break here and drink water. Okay. So now we are on mechanical ventilation. Mechanical ventilation is the process by which gas is moved to and from the lungs by an external device to artificially support their functions. It may be invasive via tracheostomy and a tracheal tube or non-invasive as in mask. Indication for invasive mechanical ventilation. Indication for mechanical ventilation include but are not limited to inadequate oxygenation, like acute hypoxemia, for example, atelectasis, small airway parenchymal disease. Inadequate ventilation, acute hypercapnia, for example, flail chest, or inadequate ventilation. Inability to maintain airway, trauma, intoxication, post-ictal state, and hemodynamic instability. Key factor is inflated chest, multiple rib fractures result in floppy segment that moves paradoxically due to negative intrathoracic pressure on inspiration. By increasing positive intrathoracic pressure, positive pressure ventilation improves oxygenation and causes the flail segment to move normally. Ventilator mechanics. This table depicts changes in lung pressures during ventilation. This table shows abnormal ventilation waveform and explains the significance. Okay, so let's look at those. Okay. All of these are so draining. Airway pressure, PP. Inspiration, expiration. So inspired, airway pressure increases, and then you expire, so it goes down. And then you come back. So positive airway pressure, so it keeps it above this line. And then inspiration comes back. This is called the inspiratory hold. And then it continues the time, and then you drop down, expire. And then this is the expiratory hold, I guess. Okay. So this is the diving pressure. This is the resistive pressure. This is the elastic pressure. Okay. This is the peak pressure, airway resistance, resistive pressure, and this is the pressure from lung compliance. Right. Airway pressure time curve. Definition. Peak inspiratory pressure. So, total pressure required to push air into the lung, P peak. Resistive pressure plus elastic pressure plus PEP. Plateau pressure. Okay. That's P plat. Reflects lung compliance. Increase in P plat decrease equals to decrease in lung compliance. Okay. And inspiratory hold maneuver allows measurements of P plat. Resistive pressure. It reflects resistance to airway flow. So P peak minus P plat. Resistive pressure comprises ventilator circuit, endotracheal tube, and patient airway resistance. Okay. Positive and expiratory pressure. Pressure at end expiration normally equals atmospheric pressure. When there is incomplete emptying of air, and intrinsic positive and expiratory pressure may develop. Auto PEEP can be measured in passive patients through an end expiratory hold maneuver. PEP may be applied by ventilator settings for therapeutic indications, prevent airway collapse. Elastic pressure, also known as diving pressure, is this diving board thing looking is the diving pressure. Due to elastic recoil of the lungs and chest wall and to the volume of gas delivered, may be derived from P plat and PEEP. So elastic pressure equals P plat minus PEP. So P plat is going to have a higher pressure than this one, PP. So this subtract this will give you elastic pressure. All right. And now ventilator settings. Key initial settings for volume assist control follow. Tidal volume is set at 6 to 8 in obstructive lung disease. For example, chronic obstructive pulmonary disease. or 6 in ARDS. Okay, so ARDS, 6 to 8 in obstructive pulmonary disease. Okay, the rate is generally set lower for obstructive disease as opposed to ARDS. So 10 to 14 per minute in OBS. Okay, 10 to 14 in obstructive, and 14 to 18 in ARDS. Okay. However, specific settings vary based on disease process and ABG. Fractional inspiratory oxygen is initially started at 100% and titrated down to maintain arterial oxygenation saturation of 88% to 95%, or PO2 55 to 80 mmHg. Ideally, FiO2 is reduced to less than 60% to prevent oxygen toxicity. Use ARDS-NET PEP FiO2 table for guidance on PEP for ARDS management. This is to prevent barotrauma. For obstructive disease, start with PEP of 0 to 5 centimeter H2O. Okay. So let's do these 2 points again. Fractional inspiratory oxygen. So you're gonna give 100%. You're gonna start off with 100%, and you keep titrating it down up till you get a saturation of 88 to 95%, or a PaO2 of 55 to 80 mmHg. Ideally, you want FiO2 to be reduced down to 60% to prevent oxygen toxicity. Right? This is the second time they told us this. Use ARDS-NET, so that's positive and expiratory pressure over fractional inspiratory oxygen. Okay, so if you're giving 60% and PEP is set up, then the ratio table for guidance on PEP and for ARDS management. This is to prevent barotrauma. You don't want to give too much oxygen past the amount of pressure you're already creating through the PEEP, right? Because that will just burst out the alveoli then and cause barotrauma. So that's why you want to keep it under this. You don't want this to be over 1, equal to over 1 or more. You want the fraction to be lower than 1. Okay. So for obstructive disease, start with PEP of 0 to 5 centimeters centimeters H2O. Okay. Inspiratory-expiratory ratio. In obstructive lung disease, the inspiratory to expiratory time ratio is higher, more than 1/3, because it takes longer for the expiration to happen because there's loss of elasticity in this. Whereas in restrictive, there's no loss of elasticity, so it's going to be normal. Okay, or maybe even faster because of the restriction from the lung walls or something else. So in obstructive, sorry, let me grab water real quick. Okay. So in obstructive lung disease, the inspiratory to expiratory time ratio is higher, 1 to 3, than the ARDS. That's acute respiratory distress syndrome, where you have inspiration at 1 and E at more than that. Okay, so 1.5. This is needed because the lungs take more time to effectively empty due to the obstructed airways. After initiation of ventilation, changes in the settings should be based on ABGs. Refer to this table. 214-10. We'll get to it. Complications of mechanical ventilation. Ventilation is associated with multiple complications. Okay, so again, for this point, we use ARDS for guidance, so we don't go add more pressure to what PEP is holding at to avoid barotrauma. And you start PEP with 0 to 5 centimeters, whereas if you're giving oxygen, we start at 100% and we titrate it down to where we get a saturation of 88% to 95%. Okay, ideally we want FiO2 at 60 or lower. And the IE ratio for obstructive disease is 1/3, whereas for ARDS it's 1/1.5, so lower than that, right? And so ventilation associated with multiple complications, including ventilator-associated lung injury and hypertension. Ventilator-induced lung injury. Acute lung injury. Did I miss any key facts here? Nope. Acute lung injury inflicted by mechanical ventilation that may result in increased mortality and morbidity. Some mechanisms are described. Okay, so what is volutrauma? This is caused by excessive stress by high tidal volume. This can be prevented by using lower tidal volumes. Barotrauma, due to high pressures. In ARDS, a lung protective strategy, plateau pressure you want at less than 30 centimeter H2O, minimizes barotrauma. Right, so plateau pressure, so they're talking about this right here. You want to keep it at 30 centimeters or lower to prevent, where'd it go? Right, barotrauma, or minimize it. Atelectrauma, this is due to cyclical opening and closing of alveoli. This can be minimized by increase in PEP. Okay. So when you increase the pressure in the alveoli, it will prevent it from collapsing inwards, right? So to prevent that, we can give more air in there, and that will prevent that, minimize it. Biotrauma, due to inflammatory mediators, possibly caused by other forms of trauma. Okay. Oxygen effect, possibility for high fraction inspired O2 to cause lung damage, FiO2. Okay, this is less likely add FiO2 less than 0.6. So again, this is the third time they're mentioning that. Key fact: in left heart failure, PEP is beneficial as increased intrathoracic pressure causes decreased preload and decreased afterload. On the other hand, increase in PEP versus right heart failure. Okay, so left heart failure, PEP is beneficial as it increases intrathoracic pressure, causing decrease in preload and decrease in afterload. On the other hand, increase in PEP versus the right heart failure, increase in intrathoracic and increase in pulmonary vascular pressures. Another key fact: for acute brain injury, target an SpO2 of 94% to 98% or a PO2 of 80 to 100 mmHg to prevent the brain oxygenate. To help the brain oxygenate. Both very high PEP and hypoxemia can increase intracranial pressure and cause cerebral ischemia. Right, so we give like 100% oxygen during brain injury. Okay, acute hypotension, tension pneumothorax. Acute hypertension and tachycardia and sudden increase in peak inspiratory pressure is suggestive of Tension, pneumothorax. Chest x-ray should be ordered. Okay. Pathologic waveforms during ventilation. So increased resistive airway pressure, it starts off here. If you increase it, it goes from baseline and increase. And this is the baseline plateau. There's an increase in difference with the baseline plateau. So increased resistive airway pressure. Okay. So there is an increase in peak. There is increase, and the P plat is still normal. And pathophysiology, increased airway resistance, okay, but normal lung compliance. Cause and management. Think airway, kinked endotracheal, ET tube, untangle mucus plugs, could be suction mucus plug then. Okay, so if it's ET tube related, then untangle it. Okay, so this is increased resistive. So during inspiration, there's an increased pressure. Okay. However, during expiration, it's the same. So why is there an increase during inspiration, right? So it's because there is some kind of resistance. And that's causing an increase in inspiratory peak. Okay. So management is untangle the ET tube, suction up with the mucus, and then bronchospasm, bronchodilate, right? And then narrow ET tube could be a cause. Okay. Decreased compliance. If there's decreased compliance, what do you get? So there's the baseline. There's an increase in inspiration pressure because you're also trying to overcome the inertia in the alveoli to get it in there, I guess, right? So there's increase in peak and there's increase in P plat. So this was the baseline and now there's an increased baseline. Okay. Okay, and pathophysiology, normal resistance but reduced lung compliance. Okay. Okay, so from here to here. So from here to here is maintained. From here to here. Okay, so normal resistance but reduced lung compliance. Think lung if you get decreased compliance. Okay, so how are you going to remember this? So if this is the same between the peak and plat, then it's decreased compliance. If there is increased peak, and then it's airway related. Okay, so if you get this, think lung, main stem intubation. Treatment is retract tube. Atelectasis, treatment is chest percussion and bronchoscopy. Pulmonary edema, treatment is diuretics. ARDS, treatment is low tidal volume, high PEP, ventilation strategy. Pneumothorax, treatment is chest tube. Pneumonia. Okay. Decreased venous return, high level of PEP cause increased intrathoracic pressure and decreased venous return. This may cause or exacerbate hypotension. Sedatives and opioids used in ventilated patients may cause hypertension. Okay. Decreased ventilation return. This may cause or exacerbate hypertension. Okay. So this was acute hypertension. Right, that's what we were talking about. So tension pneumothorax, acute hypertension with tachycardia and sudden increase in peak inspiratory pressure is suggestive of tension pneumothorax, chest x-ray should be ordered. If there is decreased venous pressure, that can also cause acute hypertension. Okay, this just cause they're talking about. Okay, so high level of PEP causes increased intrathoracic pressure and decreased venous return. Okay, this may cause or exacerbate that. Sedative and opioids can cause that. Okay. Coronavirus and COVID-19. RNA viruses that can infect animals and humans. Global outbreak of severe disease have been caused by coronavirus, including the severe acute respiratory syndrome coronavirus outbreak of 2002 and the Middle East respiratory syndrome coronavirus outbreak of 2012. SARS-CoV-2 emerged in December 2019, and this led to COVID-19 pandemic. This should sound familiar. The first case were reported in Wuhan, China. A detailed discussion of COVID-19 follows. Okay, did I miss any key facts? Nope. Okay. Question. Let's go through that first. A 25-year-old man is in intensive care unit is intubated. Following an acute asthma exacerbation, a repeat ABG is sent after intubation and shows a pH of 7.5, a PaCO2 of 33 mmHg, and HCO3 of 26. What adjustment, if any, should the physician make to the ventilator settings? Okay, so a repeat ABG is sent after intubation because of acute asthma. pH is 7.5, which is increased. However, metabolic alkalosis is not there because this is usually 22 to 28, I think. So this is normal HCO3. So it's going to be something to do with respiration, and PaCO2 is less. So there is hyperventilation, I believe. If any, make sure ventilation. Okay, let's see. This patient has uncompensated respiratory alkalosis caused by increased ventilation. To decrease ventilation, tidal volume can be decreased or respiratory rate can be slowed. However, reducing the tidal volume can trigger an increase in ventilatory rate, exacerbating the situation. Right, so don't reduce the tidal volume, is what they're saying. Caused by increase in ventilation. To decrease ventilation, tidal volume can be decreased or respiratory rate can be slowed. However, reducing the tidal volume can trigger an increase in ventilatory rate. Okay, and that will cause expiration again. Right, so you don't want to decrease tidal volume, I guess, is what they're trying to say, to avoid that hyperventilation and furthering alkalosis. Respiratory alkalosis. Okay. Water break. Okay. Pathogenesis. The pathogenesis of COVID-19 involves an exaggerated inflammatory response to viral infection, cytokine storm syndrome, CSS. CSS may result in fever, multi-organ dysfunction, cardiac and renal injury, or ARDS. Okay. 1419 table, ventilator settings adjustment based on ABG abnormalities. Okay. I don't like how this breaks the transition and momentum of the reading, but we'll go through this now. Ventilator setting adjustments based on ABG abnormalities. So ABG abnormality is decrease in PaO2, PaCO2, and increase in PaCO2. Okay, so if there's decrease in PaO2, partial pressure of arterial oxygen, and you increase the positive pressure and expiratory pressure, positive and expiratory pressure, or the amount of oxygen you're giving via mask or tube. PaCO2, decrease in PaCO2, that means there's hyperventilation, right? So decrease in respiratory rate or decrease in tidal volume. And if there is increase of this, that means there's hypoventilation. So you increase respiratory rate or tidal volume. Okay, so these two are pretty straightforward. For this, you increase the amount of oxygen you're giving. Ideally, you want this to be less than 0.6. Right, and you increase PP, but ideally you want it to be as low as possible, around 30 centimeter H2O. Okay. Okay, so history and physical examination for COVID-19. The virus is spread by respiratory droplets and has an incubation period of 2 to 14 days, average of 5 days. Clinical presentation ranges from asymptomatic or mildly symptomatic to severe and life-threatening disease. Patients with mild infection may present with fever and upper respiratory tract symptoms such as cough, sore throat, and nasal congestion, anosmia, and ageusia, which is loss of smell and taste. Ageusia, I guess. I guess. Loss of smell and taste, respectively, are common. Additionally, GI symptoms such as nausea, vomiting, and diarrhea are also reported with COVID-19. More serious infections may result in dyspnea, respiratory failure, ARDS, shock, or multi-organ dysfunction syndrome. Thromboembolic events such as pulmonary embolism may occur. COVID-19, so that was what, 2 years ago? What? Almost 5 years ago? Damn. Time flies. Diagnosis. Most sensitive. I guess it's because 2020, 2021, and 2022 didn't really happen. We don't consider those because that time never existed. That's why it feels like it was just 2 years ago that this started. Diagnosis. Most sensitive test. NAT, nucleic acid amplification test, also known as reverse transcription quantitative polymerase chain reactions, RT-PCR, of nasopharyngeal samples. Rapid antigen testing has lower sensitivity. However, point-of-care testing allows for immediate results and communication of advice, so patients can isolate and monitor sooner. Chest X-rays may show bilateral opacities. CT may show multifocal, bilateral, peripheral, ground glass opacities, often affecting the posterior portion of the lower lobe. Consolidation and air bronchograms. Lab findings: abnormal blood counts, for example, lymphopenia. Most common laboratory finding: thrombocytopenia, coagulation studies, for example, increase in D-dimer. Inflammatory markers: increase in CRP, and other biochemical tests, for example, increase in LDH, increase in ALT, AST, and increase in creatinine, are commonly seen in hospitalized patients. CT angiogram of chest in COVID-19 pneumonia shows dense right lower lobe and left lower lobe opacities and air bronchograms. Treatment. Mild cases can be managed at home with isolation, monitoring, and symptomatic treatment. That is antipyretics, analgesics, antitussives, and hydration. Patients with mild to moderate COVID-19 are at high risk for progression to severe disease may be treated with neutralizing antibodies and antiviral. For severe cases, inpatient care is needed. Okay. Water break again. These are getting more frequent now. Okay. Sorry about that. Prevention. Personal preventive strategies. Social distancing, maintaining distance of 6 feet, avoiding crowds, mask wearing, hand washing, use of hand sanitizers, reducing hand-to-face contact, and good ventilation. Strategies by healthcare personnel. Personal protective equipment, gowns, gloves, eye protection. While caring for patients with COVID-19, for aerosol generating procedures, an N95 mask must be used. Vaccine. Reduce severity of illness. Okay. Pulmonary vascular disease. So now we are going to be talking about pulmonary hypertension and cor pulmonale. Pulmonary hypertension, elevated mean pulmonary arterial pressure, which is more than 20 mmHg at rest. So normally at more than 20 mmHg at rest. Okay. So classified into the following groups. Group 1 to 5. 1 is pulmonary arterial hypertension or PH. Group 2 is increased pulmonary venous pressure from left side heart disease. Group 3, hypoxic vasoconstriction secondary to chronic lung disease. Group 4, chronic thromboembolic disease. And group 5 is pulmonary hypertension with a multifactorial etiology. So these aren't grouped into severity, they're just grouped into based on their etiology, right? So group 1 is pulmonary arterial hypertension. Okay, check. Group 2, it's for anyone who has a increased pulmonary venous pressure from left heart disease, right? So for any obstructive causes on the left side, that causes an increase in pulmonary venous pressure. Then you have group 3, which is hypoxic vasoconstrictive secondary to hypoxic vasoconstriction secondary to chronic lung disease, right? So these are the intrinsic factors of the lungs, and chronic thromboembolic disease, so that's number 4. Okay, and group 5 is pulmonary hypertension with a multifactorial etiology. Okay. Cor pulmonale, group 3. Okay, so hypoxic vasoconstriction secondary to chronic lung disease. So this is the group 3 one. Okay. Alteration in structure and function of the right ventricle of the heart caused by primary disorder of the respiratory system. Right-sided heart failure can occur in severe cases. Okay. History and physical examination. Presents with dyspnea, syncope on exertion, fatigue, lethargy, chest pain and or symptoms of right-sided congestive heart failure, edema, abdominal distension, and jugular venous distension. History is going to be of COPD or interstitial lung disease, heart disease, sickle cell anemia, emphysema, and pulmonary embolism. And physical examination will show loud, palpable S2, often split, a flow murmur, or an S4, or a parasternal heave. Patients may also be hypoxemic, especially on exertion. Key factors, other etiologies of embolic disease include postpartum status, amniotic fluid emboli, fracture, fast emboli. Right, so from fracture you get fat emboli, from postpartum. It's usually amniotic fluid emboli. Cardiac surgery, air emboli, and endovascular procedures, cholesterol emboli. Okay. Diagnosis. Best initial test is echocardiogram that estimates pulmonary artery pressure and assesses right ventricle function. Chest X-ray shows enlargement of central pulmonary arteries and rapid tapering of the distal vessels or pruning. Okay. ECG demonstrates right ventricular hypertrophy. Okay. Diagnostic test of choice: right heart catheterization, mean pulmonary artery pressure more than 20. Okay. Normal is 8 to 20. Okay. Treatment here is treat the underlying disease. Supportive therapy, supplemental O2 diuretics. Some patients may also benefit from exercise therapy. Consider digoxin and anticoagulation in patients with underlying left ventricular systolic dysfunction and arterial fibrillation. Group 1, that was primary PAH. You give prostanoids, beroprost, epoprostenol, iloprost, treprostinil, endothelin receptor antagonists, for example, ebrisentan, bosentan, and mekitintan. And phosphodiesterase PDE inhibitors, for example, sildenafil, tadalafil, vardenafil, can be added to improve hemodynamics and increase exercise tolerance. Some patients have vasoreactivity and respond well to calcium channel blockers. Group 4, thromboembolic disease. Surgical thromboarterectomy for thromboembolic disease. Anticoagulation is recommended for everyone. Balloon pulmonary angioplasty and rhizogot. Why it's not? Okay. Are the alternatives for chronic thromboembolic pulmonary hypertension? Okay, so these two procedures are the alternate to chronic thromboembolic pulmonary hypertension. Okay. Alternative to anticoagulation. Now, Wirchow triad for venous thrombosis. Okay. So venous stasis, endothelial injury, and hypercoagulability. So venous stasis is immobility, congestive heart failure, obesity, and increase in central venous pressure. Okay, so if you see these three things, chances are there's venous thrombosis. Okay. Then you have endothelial injury, trauma, surgery, recent fracture, or previous DVT. And then you have hypercoagulability from pregnancy, postpartum, cigarette smoking, oral contraceptive pill use, coagulation disorder, for example, protein C, protein S deficiency, factor V lane, malignancy, and severe burns. Mnemonic here, Wells criteria. Consider when the history and physical exam are suggestive of DVT to assess the risk of pulmonary embolism. So shit PMH. Symptoms of DVT, 3 points. Okay, so if they have symptoms of it, you give it 3 points. History of DVT, give it 1.5 points more. If there's a history of immobilization for more than 3 days, add 1.5 points to it as well. Tachycardia, a heart rate more than 100, 1.5. So that's shit. Symptoms of DVT, is 3 points. And then history of DVT, immobilization, and tachycardia are 1.5. Then comes PMH. That's post-op surgery within previous 4 weeks, 1.5. Malignancy is 1 point, and hemoptysis is 1 point. Total point value is 11. Okay. Pulmonary thromboembolism. An occlusion of the pulmonary vasculature by a blood clot. 95% of emboli originate from deep venous thrombosis in deep leg veins, femoral vein. May lead to, usually occurs from femoral vein, so don't go around picking, uh, you know, the veins in your calves. It's the femoral vein in the thighs, right? May lead to pulmonary infarction, right heart failure, and hypoxemia. History and pulmonary examination. Factors predisposing to thromboembolism are summarized by the Virchow triad. Presents with, so mnemonic for Virchow triad. Risk factors for venous thrombosis. VIR. VIR, Virchow for VIR, okay. So vascular trauma, increased coagulability, or reduced blood flow, like stasis, like airplanes. Okay. So it presents with sudden onset and subacute dyspnea, pleuritic chest pain, low-grade fever, cough, tachypnea, tachycardia, and rarely hemoptysis. Indicates pulmonary infarction. May have history of immobility, for example, long plane ride, bedbound. Examination that may reveal a loud P2 and prominent jugular A waves with right heart failure. Acute massive pulmonary embolism presents with hypertension, JVD, and JVD, and new onset right bundle branch block. Okay, that's new. Okay, and okay. Diagnosis. Best initial step. Calculation of modified Wells score. Okay, so that was the Wells score. So calculation of the modified Wells score right there. Pulmonary embolism unlikely if modified Wells score is less than 4. So if this score is only 4 out of 11, embolism is less likely. It was shit PMN. Shit again. Symptoms of DVT, history of DVT, immobilization, tachycardia, post-op, malignancy, hemoptysis. Okay. Best initial test is D-dimer used to rule out pulmonary embolism, high negative predictive value and sensitivity. Not specific though. If increase in D-dimer more than 500, then chest CT of chest and contrast with contrast. Or VQ scan if unable to obtain CT with contrast. If normal D-dimer, pulmonary embolism is excluded. Pulmonary embolism likely if modified Wells score is more than 4. Best initial test is CT of chest with contrast, high specificity and sensitivity as seen in this image. That is not seen. Let me see if I can see. Okay. If you remember the pulmonary embolism photo from FA from step 1, it's the same, I think, or it looks similar to that, where it's like two things going like that, to that, that, and that. Right? Comes in from that, and then there's like a blockade in the middle somewhere here. So you get that straddle thing happening. So that's what this looks like. All right. 214, 11, 12. Okay, so ventilation perfusion, VQ scan. Used with CT scan used when CT scan is contraindicated. So increase in creatinine, relative contraindication to contrast, right? So you don't want to give contrast when you have increased creatinine because it can cause further kidney injury. Pregnancy, contraindication to radiation, may reveal areas of VQ mismatch to predict low indeterminate or high probability of pulmonary embolism. A VQ scan is sensitive for pulmonary embolism but not specific, especially if there is underlying lung disease. ABGs, respiratory alkalosis caused by hyperventilation, decrease in PO2 less than 80 mmHg and decrease in PaCO2. Chest X-ray may appear normal or show atelectasis. Pleural effusion, Hampton hump, a wedge. Yeah, so this is what it was: a wedge-shaped infarct or Westermarck sign. Oligmia, collapse of vessels seen distal to pulmonary embolism. Okay, so all of these things will diagnose it for you. Okay, so they just gave us shit PMN again. Signs and symptoms of DVT is 3 points. Pulmonary embolism, most likely clinical diagnosis, 3 points. Tachycardia, 1.5. Immobilization, 1.5. DVT, pulmonary, previous DVT or pulmonary embolism, 1.5. Hemoptysis is 1. Malignancy is 1. Traditional clinical probability assessment, high more than 6. Moderate is 2.6. Low is less than 2. Simplified clinical probability assessment, pulmonary embolism is likely if it's more than 4. Pulmonary embolism is unlikely if it's less than 4. ECG most commonly reveals so ECG most commonly reveals sinus tachycardia. The classic triad of S1Q3T3 is rare. Acute right heart strain with a S wave in lead 1, a Q wave in lead 3. Okay, so that's what this is, which is acute right heart strain with S wave in lead 1. Okay, a Q wave in lead 3 and an inert T wave in lead 3. S1 Q3 T3. Let's look that up. S1 Q3 T3. Okay, so that's S1 in 1 and then Q3 and T3 in lead 3, right? So that's T3 and that's Q3 and that's S1. Let's look at one more of these. In 1 you see S wave there. In lead 3 you see Q wave in there and that. No. Nope. Why are these images so bad? Okay. Q3, T3. Okay. S wave. And we'll just go back to this. Okay, so you have inverted T3. The S wave is large here because rather than the Q wave, right? And here you have the Q wave, so QRST, right? So Q wave is longer here, and then T wave is inverted, and here you have the S wave instead of the Q wave in lead 1. So S1, Q3, T3. Okay, I think we got the hang of it now. So again, ECG, and we're doing embolism. What we see there is most commonly reveals sinus tachycardia. The classic triad of S1, Q3, T3 is rare with this type of tachycardia. Okay, so I guess don't pay attention to that then. Lower extremity venous ultrasound, specific and sensitive for DVT, which may be the cause of pulmonary embolism. Okay, so do the ultrasound in the lower extremity, specific and sensitive for DVT, which may be the cause of pulmonary embolism. Okay, key fact here is dyspnea, tachycardia, and a normal chest X-ray in a hospitalized and or bedridden patient should raise suspicion of pulmonary embolism. Right, because you got stasis, so that should hit there as well. Treatment, anticoagulation, 14-13. This one right here, we'll do that after treatment. Actually, let's do that before treatment. Another key fact, lung nodule clues based on history. Recent immigrant, think TB. From the southwestern United States, think coccidiomycosis. From Ohio river valleys, think histoplasmosis or blastomycosis. Okay. This is the one with desert bumps as well. This one causes palatal ulcers, I think. Or was it this one? It was one of these, and I believe it was this one. And this one causes... No, this one was the palatal ulcer one. And this one was the one with ulcers that look like squamous cell carcinoma. Let me go check it out before we move on. So palatal ulcers, tongue ulcers. Okay, so that was histo. They have palatal ulcer, tongue ulcers, similarly pancytopenia, erythema nodosum. Okay, so erythema nodosum happens in histoplasmosis, and blastomycosis, inflammatory bowel disease disseminated to skin. Varicose lesions may mimic squamous cell carcinoma, blastomycosis. This is the one with the desert bumps. Right, okay. Good little recap to that. Okay, anticoagulation and suspected PE. Contraindication to anticoagulation. Sorry, contraindication to anticoagulation. Yes or no? Yes. Diagnostic evaluation. And you do PE confirmed, then IVC filter, and if you do the diagnostic evaluation and PE is not confirmed, then no further evaluation for suspected PE. You don't just send them home. You see what else is wrong with them. Okay. So if there's anticoagulation contraindication, then you go this route. If there is no contraindication, then you go this route, which is clinical suspicion of PE. Then if it's high, then you start empiric anticoagulation right away. If it's moderate to low, then we'll take our time and diagnose it through evaluation. If it works, then good for you, and you start and continue anticoagulation as you should have anyways. And if diagnostic evaluation doesn't seem like it's PE, then do better and no anticoagulation, discontinue if started empirically. Okay, let's go back to this. Now, anticoagulation. Acute. If it's acute, unfractioned heparin, subcutaneous low molecular weight heparin, LMWH, subcutaneous fondaparinux, or direct oral anticoagulants, or they call it DOAC, right? These are your rivaroxaban and apixaban. In patients with high probability, so 10A, right? That's what they do. They block. And they have a better affinity towards 10A than thrombins, which are 2A's, right? Heparin works better on 2A than 10A. In patients with high probability of pulmonary embolism, anticoagulation should be given before confirmatory testing. Patients with renal failure require unfractioned heparin or apixaban. Okay, so if there's renal failure, they require unfractioned heparin or apixaban. Okay, in patients with high probability of pulmonary embolism, anticoagulation should be given before you evaluate it and diagnose it. Okay, in patients with renal failure, you give unfractioned heparin or apixaban. Okay, and yeah, okay. Chronic lower molecular weight heparin, direct oral coagulants are preferred, or warfarin. Goal for international normalized ratio is 2 to 3. Use LMWH in pregnancy. Warfarin is contraindicated. Inferior vena cava filter indicated in patients with a documented lower extremity DVT, pulmonary embolism if anticoagulation is contraindicated, or if patients experience recurrent emboli while on therapeutic doses of anticoagulation. So you put in, a Brita filter, so that will prevent the embolus to reach the lungs. Thrombolysis indicated in cases of massive pulmonary embolism causing right heart failure and hemodynamic instability. Settle pulmonary embolism. DVT prophylaxis. Treatment for all immobile patients. The physician should prescribe subcutaneous heparin or low dose, low molecular weight heparin. Early ambulation most effective, and intermittent compression of the lower extremities but that is less effective. Early ambulation is more effective. Okay. Did that. Okay. Guide to anticoagulation in hemodynamic stable patient with a suspected PE. Contraindications to anticoagulation include recent surgery, hemorrhagic stroke, active bleeding, and aortic dissection. Clinical suspicion of pulmonary embolism is determined using the modified Wells criteria. High is more than 6, moderate is 2 to 6, low is less than 2. If diagnostic evaluation cannot be completed within 4 hours, start empiric coagulation, anticoagulation. Water break. Alright, so welcome back on this ASMR session of pulmonary. Neoplasms of the lungs. Solitary pulmonary nodules, commonly found on chest x-rays. History, physical exam, and imaging features help guide treatment. History and physical examination. Often asymptomatic, may present with chronic cough, dyspnea, and shortness of breath. Necessary to always inquire about smoking and exposure history, which are associated with increased cancer risk. Diagnosis and treatment. Best initial test is chest X-ray. CT scan of the chest. The physician should obtain a non-contrast CT of the chest if a nodule was discovered on another modality. If a nodule has fat or calcifications characteristic of a benign lesion, for example, hematoma, granuloma, no further evaluation is required. If a nodule does not have characteristic of a benign lesion, the next step is to review the medical record for a previous CT if available. If the nodule is old and the size is stable for more than 2 years, no further evaluation is required. If the nodule is new, increasing size, and no prior CT scans are available, then determine risk for malignancy. Risk for malignancy in patients with solitary pulmonary nodules. Variable. So diameter of nodule in low, it's going to be less than 8, or 8 to 20 for intermediate, and more than 20 or more, it's going to be what? This should be 19 in that case. Okay. 8 to 19 intermediate, 20 or more, it's going to be high. Nope. Yep. More than 60. Okay, this one's right. For age, low malignancy risk is in less than 45 years old. 45 to 60, it's going to be intermediate risk, and more than 60, it's high risk. Smoking history is low, never in low risk. Years since smoking cessation is more than 15. Nodule characteristics are smooth, and calcification, it's central, uniform, or popcorn calcification. So again, for low risk, nodules are less than 8 mm. The patient is less than 45. They don't have a smoking history, or if there is a smoking history, then it's going to be more than 15 years of cessation. Nodule characteristics are smooth, and calcification central, uniform, or popcorn calcification. For intermediate, diameter 8 to 19. Age is going to be 45 to 60. Smoking history is yes. They do have a smoking history, and cessation is going to be anywhere from 5 to 15 years. Nodule characteristic is scalloped, and calcification is nothing. High. Diameter of nodule more than 20 or more. Age more than 60. Smoking, there is smoking history, and cessation has been less than 5 years. Nodule characteristic is going to be corona radiata or spiculated. Calcification is absent or irregular calcification. Determine risk for malignancy. So if it's benign features, you do serial CT scans. If it's low to intermediate, determine the nodule size. If it's less than 4 mm, there is malignancy risk. Malignancy risk, then intermediate, then serial CT. If it's low, then no further evaluation. You do the nodule size, and it's 5 to 7 mm, serial CT scan. If it's more than 8 mm, PET or biopsy. And if there's no suspicion for malignancy, you just monitor it with serial CT scans. And if it's suspicion for malignancy, then surgical resection. And if the risk for malignancy is high, you just go in and cut it out. Okay. Mnemonics. Squamous and small cell carcinomas are central. Okay. Low risk. Serial CT scans. Intermediate risk. Further investigation required with biopsy or positron emission tomography or PET. And for high risk, go in and cut it out. Lung cancer. Okay, before we start that, 25-year-old woman presents with dyspnea, chest pain, and leg pain. She takes birth control pills regularly. She returned from Asia 3 days ago. What is the next step? Put them on anticoagulants. Or yeah. The next step is to treat with a heparin bolus or lower molecular weight heparin. When there is high clinical suspicion, birth control, history of long flight, multiple symptoms, for a DVT PE, one should treat first and follow with imaging, CT angiogram. With patients who have a lower clinical suspicion, imaging is warranted first before treatment. So if it's low suspicion, do the imaging, and if there's high, then you treat it and then do the imaging. Okay. All right. Mnemonic for lung cancer metastases are often found in labs. Labs for L for liver, adrenals, brain, and bone. Okay. Sorry. Okay. Lung cancer. The leading cause of cancer death in the United States. Risk factors include tobacco smoke, except for bronchoalveolar carcinoma and radon or asbestos exposure. Types are as follow in this table. Okay, so we can go through this and then we'll go through the history and presentation. Okay, so small cell or oat cell carcinoma, it's central. Again, small cell and squamous cell carcinoma are central. Okay. Characteristic, when they say central, they just mean for someone who's not done step 1 yet and giving step 2 first. It's going to be in these areas, carcinoma, right? So central location, highly correlated with cigarette smoking, undifferentiated and very aggressive. Patients have low, medium survival rate and or poor prognosis. Metastasis often found on presentation in intrathoracic and extrathoracic sites such as brain, liver, and bone, or labs, right? Again, adrenals, liver, brain, bone. Okay. Differentiated, where was I? Right there. Associated with paraneoplastic syndrome, may produce ACTH or like Cushing syndrome. So if there's anything about that, or SIAD, or serum of inappropriate secretion of ADH, or antibodies against presynaptic calcium channels, or Lambert-Eaton myasthenic syndrome, or neurons, paraneoplastic myelitis, or encephalitis. So it's associated with all of these things. So if you have lung symptoms, you have any of these symptoms with imaging finding of some kind of opacity in the imaging, then you can think of this. Rarely operable, treat with radiograph therapy for primary tumor at early stage and to prevent palliative brain metastasis. Chemotherapy for metastatic disease. History. Neoplasm of neuroendocrine Kolchitsky cells. Small dark blue cells. Chromogranin A positive. So that's one way to remember that, and you can remember neoplasm of neuroendocrine cells. They used to test this in step 1. Small and dark blue cells are an easy way to remember this. Okay, so this was small cell carcinoma. Now non-small cell. Less likely than small cell lung cancer to metastasize at an early stage. Okay. So this one has more chances of metastasizing. Okay, adrenocarcinoma, it is peripheral. So when they say peripheral, they mean on the outer edge. It's found, not centrally. Most common lung cancer in female, non-smokers. They say this, but any question in step 1 that we went through in UWorld, um, this they rarely were non-smokers. They always had a history, from what I remember. So don't take this too seriously. Most common lung cancer in female patients, non-smokers, and overall, except for metastasis, activating mutations including KRAS, EGFR, and ALK translocation, associated with hypertrophic osteoarthropathy, clubbing. Okay, so if there's clubbing, think of this. Bronchoalveolar subtype, adenocarcinoma in situ, chest X-ray often shows multiple nodules, interstitial infiltration, and prolific sputum production, often confused with pneumonia. Good prognosis, decreased association with smoking. Patients have favorable prognosis. Okay, so histology, what you can find, glandular pattern on histology often stains mucin. Okay, and so mucin positive. Bronchoalveolar subtype, it grows along alveolar septa, right? And shows apparent thickening of alveolar walls. Okay, activating mutations are KRAS, EGFR, and ALK. KRAS, remember, K, R, A, and S. So it was related to lung cancer, pancreatitis, pancreatic cancer, and colon cancer. That one. ALK alpha was for lung cancer in that as well. I remember EGFR right now. Squamous cell carcinoma, central, hilar mass arising from bronchus, cavitations, cigarettes, hypercalcemia, produces PTH related peptide, strongly associated with smoking. Okay, so squamous cell carcinoma are associated with PTHRP. Remember that. Hilar mass rising from bronchus, cavitations, cigarettes, and hypercalcemia. Right, so hypercalcemia in this, and don't confuse it with the antibodies against calcium channels with this. Okay. So hypercalcemia in that, and Cushing's in this. Okay, keratin pearl and intercellular bridges are seen in this, and usually that's what it looks like, right? It's like that, and then like a onion, or like that, and that's what the pearl looks like. Just Google it if you don't remember or don't know yet. Large cell carcinoma, peripheral, high-grade neuroendocrine tumors sharing hallmarks of both small cell and non-small cell lung cancers. Poor prognosis, less responsive to chemotherapy, and surgical removal is what you want to do. There's pleomorphic giant cells in this. Bronchial carcinoid tumor. This is often the neglected one that we don't remember much details about. So, bronchial carcinoid tumor. Favorable prognosis, metastases are rare. Symptoms usually caused by mass effect. Occasionally, carcinoid syndrome happens, so 5-HT secretion, so that will cause flushing, diarrhea, and wheezing. Nests of neuroendocrine cells, chromogranin A positive. Okay, so now back to history and presentation for lung cancer. Cough, hemoptysis, dyspnea, wheezing, pneumonia, chest pain, weight loss, and possible abnormalities on respiratory exam, crackles, and atelectasis. Okay. Superior sulcus tumor or Pancoast tumor, tumor on the apex of the lung adjacent to the subclavian vessels. Presentation is dependent on which of the following structures are compressed: brachial plexus, shoulder pain, most common initial pain symptom, and arm pain, C8 to T2 reticular pain. Paravertebral sympathetic chain and inferior cervical stellate ganglion, Horner syndrome, meiosis, ptosis, and hydrosis. Superior vena cava syndrome is obstruction of the SVC with supraclavicular venous engorgement and facial swelling. Hoarseness, secondary to recurrent laryngeal neural involvement. Many paraneoplastic syndromes. Okay, all of these are images for the cancer that they told us about. And so AB is not there, but C is adenocarcinoma of the lung, and this is histology of squamous cell carcinoma. So keratin pearl is this thing right here. I can't tell which one is that. And this shows histology of squamous cell carcinoma with prominent nuclei, mitosis, and necrosis. So there's no keratin pearl in this one, but normally you would see it, right? And yeah. Oh, I think it's this thing right here. Okay. Diagnosis. Best initial test. Chest x-ray of CT of the chest. If initial test raises suspicion for malignancy, the physician should obtain a tissue sample next. Most accurate tests: fine needle aspiration CT guided for peripheral lesions and bronchoscopy, biopsy or brushing for central lesions. Once diagnosed, establish PET. CT is done for PET scan, PET or CT. PET or CT scan is done for staging. This is superior vena cava syndrome. Prominent JVD is seen there in SVC syndrome, secondary to obstruction of the SVC by central malignant lesion. Okay, treatment here is treatment of small cell carcinoma, SCLC, and non-small cell lung cancer. Varies according to the stage. Early stage disease requires surgery with or without adjuvant therapy, chemotherapy, immunotherapy, or radiotherapy given prior to surgery. Neoadjuvant therapy aims to decrease the size of a tumor. Adjuvant therapy, okay, so neoadjuvant, we are decreasing the size. Adjuvant therapy is given right after surgery to decrease chances of residual disease. So there's that. For advanced stage disease, systemic therapy is the best recommended approach for some inoperable tumors, stage 3, or in patients unfit for surgery. Chemotherapy and radiation alone may sometimes be curative. The regimens of systemic therapies differ according to the histology, but the principles remain the same. Type of systemic therapies include chemotherapy aims to kill rapidly dividing cells. It is an imprecise way of preventing cancer growth. However, chemotherapy prevents growth of not only cancer cells but also normal cells of the GI tract and others. It can therefore cause adverse events such as diarrhea, nausea, and hair loss. Okay. Again, chemotherapy aims to kill rapidly dividing cells. That's what this is for. It is an imprecise way of preventing cancer growth. However, chemotherapy prevents growth of not only cancer cells but also abnormal cells of the GI tract and others. It can therefore cause adverse events such as diarrhea, nausea, and hair loss. Targeted therapy aims to block cancer cells harboring a driver mutation, for example, EGFR mutation or ALK mutation. Immunotherapy aims to activate the immune system to fight cancer cells. For example, examples are immune checkpoint inhibitors, for example, anti-programmed death PD-1 inhibitor, anti-programmed death ligand PD-L1 inhibitor, and anti-cytotoxic T lymphocyte associated antigen 4, anti-CTLA-4, PD-1 and CTLA-4 are checkpoint regulators present on immune cells. When PD-1 is bound to its ligand present on the cancer cell, it prevents activation of the immune system. Okay, that was a lot. Okay, so remember it was something like this, on the cytotoxic cells, T lymphocytes, and then you have a cancer cell that comes in with a PD-1, and this is the ligand, PD-1. So when this comes and attaches to this, it basically renders this useless. So to prevent that, we give setlove4. So setlove4 will come in and attach to this. So then when this gets detected, this thing is not rendered useless and is effective. I believe that was the mechanism of action for that. Okay. Question. And there's no key facts here. Okay. 65-year-old patient with a 30-pack history presents with 2-week history of facial swelling. CTM examination reveals a hilar mass, and biopsy reveals small cell lung cancer. What is the next treatment? So there is facial swelling, so we are seeing stuff happening. Right, and it's hilar. So the mainstay of therapy for SCLS is chemotherapy, which yields high rates of response. It is next step in treatment. Okay. It's rarely operable, so treat with radiotherapy, it says here. So why is... Wait, did I read that right? It says chemotherapy, right? Yeah, so mainstay of therapy for SCLS is chemotherapy. And here they're telling us it's radiotherapy. Where'd it go? Right here. Treat with radiotherapy for primary tumors at early stage and to prevent palliative brain metastasis. Okay. And chemotherapy for metastatic disease. So we don't know if this is already metastatic though. I guess just make a call. If it seems like it's metastatic, then you go with that. Or maybe they did it because of the age. They went with that. Because it's not an early stage anymore, right? So maybe that's why they went with chemotherapy. I'm not sure, but okay. We'll take that on face value. Okay. Paraneoplastic syndrome of lung cancer, classification, syndrome, and histologic type. Endocrine or metabolic. These are your syndromes are Cushing syndrome, SIAD, leading to hyponatremia, hypercalcemia, or PTHRP, and gynecomastia. Histology is going to be non-self for this. But if you see hypercalcemia, remember PTHRP is squamous cell, and gynecomastia is going to be your large cell. Large cell. Okay. Skeletal. Hypertrophic pulmonary osteoarthropathy or clubbing. You see it in non-small cell. Neuromuscular. Okay. So peripheral neuropathy, small cell. Subacute cerebellar degeneration, small cell. Myasthenia Lambert-Eaton, syndrome, small cell. Dermatomyositis, that can be seen in all of them. Cardiovascular, migratory thrombophlebitis, adenocarcinoma, non-bacterial verrucous endocarditis. There's going to be adenocarcinoma, hematologic, anemia in all, DIC in all, eosinophilia is seen in all of them, thrombocytosis is seen in all of them, hypercoagulability is seen in all of them, cutaneous, actinosis nigricans, all of them. Okay. Respiratory tract infection. So note epiglottitis, laryngotracheobronchitis, and bronchiolitis are mostly seen in infants. Please refer to pediatric chapter for a discussion of these entities. Okay, I'll do that right away, sir. Pneumonia. Bacterial, fungal, or viral infection of the parenchyma of the lungs, history and physical examination. Living conditions and social history is into the week's preceding presentation. Comorbidities and history of hospitalizations can all give important clues to determine the most likely pathogens. Classic presentation: acute onset of fever, productive cough, purulent yellow-green sputum or hemoptysis, dyspnea, night sweats, and pleuritic chest pain. Symptoms may be subtle in immunocompromised older adults. Patient, okay. Atypical presentation: gradual onset, dry cough, headache, myalgia, sore throat. GI symptoms can be seen with viral pneumonias and infection with fastidious organisms like Legionella, Mycoplasma pneumoniae, and C. pneumonia. Legionella pneumophilia. Lung examination may show decrease of bronchial breath sounds, rales, wheezing, dullness to percussion, agophony, and or tactile fremitus. Okay. Did I miss any notes? Nope. Okay. So causes of pneumonia by category. Typical bacterial, then it could be Streptococcus pneumoniae, H. influenza, Moraxella catarrhalis, Staphylococcus aureus, or group A strep gas. Atypical bacteria is going to be Legionella, Mycoplasma pneumoniae, C. pneumonia, or Chlamydia tisaki. Respiratory viruses: influenza A and B, SARS-CoV-2 and or coronavirus, rhinovirus, parainfluenza virus, and adenoviruses. Okay, and yeah. Alright, so mnemonic. Curb 65 score for pneumonia severity. Pneumonia hospitalization criteria is 3 to 4. So consider inpatient for 3 to 4, and if it's more than 4, consider ICU. C for confusion, uremia, respiratory rate. B for blood pressure. And if they're more than 65, these are the criterias. So confusion, uremia if BUN is more than 19, respiratory rate is more than 30, and BP if it's less than, systolic is less than 90, and diastolic is less than 60. Okay, cool. Moving on. Did we do this already? 70-year-old man presents to the emergency department with 5 days of fever, productive cough, and altered mental status. He is also found to be hypotensive and tachypneic. Broad-spectrum antibiotics and fluid resuscitations are promptly administered, but the patient continues to be hypotensive. What is the next best step in treatment? The next best step in treatment entails administration of vasopressors and ICU admission. This patient is in septic shock, probably secondary to pneumonia. Patient with pneumonia who require vasopressors or mechanical ventilation warrant admission to an ICU. Okay. The diagnosis of pneumonia is made in the setting of suspicious clinical context and compatible chest imaging findings. Chest X-ray is the best initial diagnostic test. If chest X-ray does not reveal clear infiltrate and suspicion for pneumonia is high, a non-contrast CT or the chest can be obtained for more detailed visualization of the lung parenchyma. Severity of illness determines best management setting. Inpatient versus outpatient and recommended diagnostic workup. Routine blood work, CBC, metabolic panels should be obtained for all patients. For patients treated in the outpatient settings, influenza testing can be considered if they are candidates for antiviral treatment with oseltamivir. Otherwise, no additional workup is needed unless there is failure to respond to initial treatment or if there are risk factors for resistant organisms, recent hospitalization, structural lung disease. For patients treated in the hospital, blood cultures and sputum gram stain and culture are indicated, as well as respiratory viral testing, Legionella testing, and urine streptococcal antigen testing. Testing for atypical organisms, those that are difficult to culture on standard culture media, can be considered if clinical suspicion is high. Clinical and social context is important when trying to determine the most likely pathogen in a patient with pneumonia. Common causes of pneumonia are outlined here and illustrated here. Okay, so we'll go through that now. Causes of pneumonia by risk factor and associated conditions. Alcohol use disorder, etiology, S. pneumonia, Klebsiella, Actinobacter, oral anaerobes, aspiration, enteric gram negatives, and oral anaerobes. COPD, H. influenza, Moraxella catarrhalis, S. pneumonia, Pseudomonas legionella, exposure to animals, bird, avian influenza, C. Psittaci, birds or bats, then Histoplasma capsulatum, rabbits, it's Francisella tularensis. This one that causes tularemia. Farm animals, Coxiella rhinetid. This is from the amniotic sac of an animal, and the one that causes Q fever. HIV, AS, pneumonia, H. influenza, Mycobacterium tuberculosis, particularly in early infection. Okay, so HIV, Mycobacterium tuberculosis. Pneumonitis jirovecii, I think that's how you pronounce it. Cryptococcus, Histoplasma aspergillus, atypical Mycobacteria, Pseudomonas. Recent travel, hotel or cruise, think Legionella. Southwest United States, hantavirus or coccidioides. Southeast East Asia, Bucraldia, Pseudomelia. And Middle East, MERS coronavirus. Structural lung disease, Pseudomonas, Bucraldia, Cepacia, and S. aureus. Post-viral Staphylococcus, S. pneumoniae, H. influenza. Injection drug use, S. aureus, anaerobes, Mycoplasma tuberculosis, S. pneumoniae, and endobronchial obstruction, S. pneumoniae, H. influenza, S. aureus, and anaerobes. Okay. Common pathogens causing pneumonia is S. aureus, is over here, cocci cluster, and then you have Streptococcus pneumonia. This is cocci in linear pattern. Sputum sample from a Patient with pneumonia. Note the characteristic lancet-shaped gram-positive diplococci. Okay, so this diplococci. If you can make it out too, right there. That I just blocked and censored. Okay, key fact here is that pneumococcal vaccine should be given to all children and to patients more than 65 years of age. Other indications for pneumococcal vaccines include chronic heart, lung, liver disease, chronic renal failure, diabetes, cigarette smoking, asplenia, immunocompromised, congenital immunodeficiency, malignancy, asplenia, cerebrospinal fluid leaks, and cochlear implants. Treatment. Empiric antibiotic choices is also determined by illness severity and local antibiotic sensitivity. If a specific pathogen is identified in diagnostic testing, antibiotic therapy should then be tailored to target it. Immunocompromised patients and those with structural lung disease, bronchiectasis, CF, have a higher risk of developing Pseudomonas pneumonia. Consider activity against this pathogen by using an anti-pseudomonal beta-lactam, for example, piperacillin tazobactam, plus either a respiratory fluoroquinolone or a macrolide. A summary of the recommended best initial treatment for pneumonia, it is given in this table. 14.18, that's there. Okay. Yeah, okay, let's go through that now. Okay. Treatment for pneumonia. Water break. Drink water. Okay. Treatment of pneumonia. Sorry. Patient type. Suspected pathogens. Empiric coverage. Patient type. Those with outpatient community-acquired pneumonia, less than 55 years of age, otherwise healthy, no antimicrobials within 3 months. Suspect that it's, so again, those with outpatient acquired pneumonia, community-acquired pneumonia, and they're less than 65 years. Otherwise, they were healthy, no antimicrobials within 3 months. Suspect S pneumonia, M pneumonia, C pneumonia, H influenza, or something viral. Empiric coverage here is amoxicillin. These are important to remember. We give amox, doxycycline, or macrolide if local pneumococcal resistance is less than 25%. Okay, if the patient is more than 65 years of age or comorbid, like they have COPD, heart failure, renal failure, diabetes, liver disease, ethanol abuse, or antimicrobial use within 3 months, then suspect again as pneumonia, but here it changes to H. influenza, aerobic gram-negative rods, for example, E. coli, Enterobacter, S. aureus, Legionella, etc. Viruses. Okay, Klebsiella. Combination of amoxicillin and clevolunate. What is this combination called? Augmentin, right? So you give augmentin or cephalosporin plus macrolide or doxycycline. Okay, so you give amox and clevolunate combination, or cephalosporin plus macrolide combination, or doxycycline or respiratory fluoroquinolone monotherapy. Okay, so if they're 45 and they have comorbidities or they have used antimicrobials within the past 3 months, then you give combinations. Here, if it's less likely that you suspect pneumonia in them, then, or less than 65, haven't used antimicrobials, we give monotherapy of amox, doxy, and macro. Okay. Patients with community-acquired pneumonia requiring hospitalization: H. pneumonia, H. influenza, anaerobes, aerobic GNRs, Legionella, chlamydia, respiratory fluoroquinolones, or beta-lactams plus macrolide. Community-acquired pneumonia requiring ICU care: S. pneumonia, Legionella, H. influenza, anaerobes, aerobic GNRs, Mycoplasma, Pseudomonas. Beta-lactam, macrolide, or beta-lactam with fluoroquinolones. Okay. Patients with hospital-acquired pneumonia, GNRs, include Pseudomonas or Actinobacter, S. aureus, Legionella, and mixed flora. Anti-pseudomonal agents to start if structural lung disease is present. Addition of second anti-pseudomonal agent if patient is critically ill, in shock, or requiring ventilator support due to pneumonia. The physician should use 2 anti-pseudomonal agents plus an anti-MRSA agent. Okay, so let's do that again. Community-acquired pneumonia requiring ICU. You suspect these, and then you give beta-lactam with macrolide or beta-lactam with fluoroquinolone. If it's a hospital-acquired pneumonia, you gotta go stronger than that, and you give anti-pseudomonal agent, piperacillin tazobactam. If structural lung disease is present, addition of second anti-pseudomonal agent. Okay, so that one, okay, piperacillin and then tazobactam. If patient is critically ill, in shock, or requiring ventilator support due to pneumonia, the physician should use 2 anti-pseudomonal agents plus add a anti-MRSA agent. Okay, vancomycin, linezolid. In the United States, the typical influenza season, we haven't done that yet. Okay, so influenza now, onto that. Cool. Influenza, a highly contagious orthomyxovirus transmitted by droplet nuclei. There are 3 types of influenza: A, B, and C. Subtype of influenza A. For example, H5N1, H1N1. These aren't visas. These are subtypes of influenza. Subtype of influenza A are classified based on glycoproteins, hemagglutinin H, and neuraminidase N. Relevant terms are as follow. Antigenic drift refers to small gradual changes in surface proteins through point mutations. Okay. These small changes are sufficient to allow the virus to escape immune recognition, accounting for why individuals can be infected with influenza multiple times. Antigenic shift describes an acute major change in the influenza A subtype. Significant genetic reassortment and circulating among humans lead to pandemic. So drift is not as intense and hostile, right? It's very small changes, gradual changes, and they happen over time. Whereas shift, it's major changes and it circulates amongst humans. Okay. Here, these small changes are sufficient to allow the virus to escape immune recognition, accounting for why individuals can be infected with influenza multiple times. Here, it leads to pandemics. Okay. In the United States, the typical influenza season begins in November and lasts until April. So, suspect influenza for these. Normally, when in the vignette, they probably use like around Christmas time or in January, but it can go from November up till April. Yearly vaccination with inactivated influenza virus is currently recommended for all patients more than 6 months of age. Children 6 months to 8 years of age require 2 doses of the seasonal vaccine. If they are receiving the vaccine for the first time, a high-dose flu vaccine is available for people more than 65 years of age or those who are immunocompromised. History or physical examination. Okay, so let's read the vaccine part first. Yearly vaccination with inactivated influenza virus is concurrently recommended for our patients more than 6 months of age. Children 6 months to 8 years of age require 2 doses of the seasonal vaccine if they are receiving the vaccine for the first time. A high dose flu vaccine is available for people more than 65 years of age and those who are immunocompromised. Okay. History and physical examination. Patients typically present with abrupt onset of fever, myalgia, chills, cough, coryza, and weakness. Other adult patients may have atypical presentation characterized only by confusion. Okay, so nothing else, just confusion. Okay. Diagnosis. Best initial test is rapid influenza test or viral antigens from nasopharyngeal swab. Most accurate test is diagnosis can be made with direct fluorescent antibody test, viral culture, or PCR assays. Rapid influenza tests have low sensitivity and influenza is usually a clinical diagnosis. Leukopenia is a common finding. Okay, so leukopenia. Um, Interesting. Okay, so best initial test is this rapid influenza test. However, here they have said that rapid influenza tests have low sensitivity and influenza is usually a clinical diagnosis, right? But anyways, rapid influenza test for viral antigens from nasopharyngeal swab. Other than that, you can do DFA or PCR or viral culture. And leukopenia is a common finding. And again, if it's anywhere from November to April, and they have coryza, myalgia, chill, fever, suspect influenza, right? And that's enough to um, give them like prescribe them symptomatic medications, or just tell them chill out. Treatment: analgesics and hydration provide symptomatic care. Yes, antivirals such as oseltamivir or zanamivir are often most effective when used within 2 days of onset and may shorten the duration of infection by 1 to 3 days. Okay, cool. Complications: severe primary viral pneumonia with ARDS, secondary bacterial pneumonia, see postviral, sinusitis, bronchitis, and exacerbation of COPD and asthma can occur. Okay, so sometimes if it's influenza is for too long, we gotta treat it with medication because these are the complications. ARDS, severe primary viral pneumonia with ARDS, secondary bacterial pneumonia, sinusitis, bronchitis, and exacerbation of COPD and asthma can occur. Okay. Aspergillosis. Okay, this is a little ball type thing right there. A group of disease caused by Aspergillus, typically Aspergillus fumigatus, through infection by spores. And Aspergillus can be seen on silver stain as acutely less than 45 degrees, branched septate hyphae. Allergic bronchopulmonary aspergillosis hypersensitivity reaction seen in people with asthma or CF, cystic fibrosis. Refer to the restrictive lung disease section of this chapter for this. We already did it. Aspergilloma. Okay. Aspergilloma. Typically discovered as an incidental radiographic finding in patients with pre-existing lung disease like TB or COPD. History or physical examination you will find is maybe asymptomatic or presents with hemoptysis. Fever or cough are less common, and that's why they go unnoticed, and these are incidental findings. Diagnosis or chest X-ray or CT reveals a solid mass within a pre-existing lung cavity. Lab tests are typically normal, and treatment antifungals are not very effective. If symptomatic, curative surgical resection or embolization for hemoptysis can be pursued. Oh, cool. So we don't give antifungals for this. If it's symptomatic, curative surgical resection or embolization for hemoptysis can be pursued. Chronic necrotizing pulmonary aspergillosis, rare antibiotic resistant pneumonia that occurs in patients with immunosuppression. Okay, so alcohol use disorder or steroid dependency COPD. Here, history and physical examination, fever, cough, hemoptysis, and night sweats, fatigue. Treatment here is voriconazole or other triazole. Rarely surgical resection can be performed if localized and severe disease. Okay. Now, invasive pulmonary aspergillosis, severe rapidly progressive infection that occurs in profoundly immunosuppressed patients, for example, chemotherapy and transplant. Infection begins in the respiratory tract and then disseminates hematogeneously. Angioinvasion leading to septic emboli. History and PE, fever, cough, pleuritic chest pain, tachypnea, and hypoxemia. Diagnosis here is serum galactomannan assay. If negative, but degree of suspicion is high, bronchoscopy with bronchoalveolar lavage, sent for galactomannan and aspergillus PCR or lung biopsy can be considered. Whew, this is the first time I'm seeing this word. Okay. Galactomannan assay. Okay, so remember that. Invasive pulmonary aspergillus, we diagnose with galactomannan assay. Treatment, voriconazole or other triazole, in addition to decreasing immunosuppression. Histoplasmosis. Risk factors include HIV and AIDS, splunking, exploring caves, and exposure to bird or bat excrement, especially in the Ohio and Mississippi River valleys. See this figure. Okay, seeing it. Blastomycosis, Wisconsin, Mississippi, the Great Lakes. Okay. Then histoplasmosis is down here. Okay, and coccidiomycosis is over there. Kidoki. I think you need to know some of these states. So if you have some time, like 5 minutes, open up Google and just look out for all the states that are in this vicinity right here. Okay, so like Wisconsin, Mississippi, and New Jersey, New York, Washington. What else? Nevada, Florida, Texas. So know where these things are, and the whole Midwestern place. Okay. Differential diagnosis of opportunistic pulmonary fungal infections. Histoplasmosis, coccidiomycosis, and blastomycosis. We'll do histo first. Disseminated disease will cause hepatosplenomegaly, lymphadenopathy, and non-productive cough. Here the diagnoses are made with urine or serum polysaccharide antigens. For blastomycosis, meningitis, bone, prostate, and skin lesions, ARDS, is caused by blastomycosis. You can think of that with uh, the way bleomycin was shown, right? So B for blastomycosis. Looks like lungs. So that. ARDS. Okay. Uh, Diagnosis. Culture showing broad-based budding yeast. And then coccidomycosis, meningitis, bone, lesion, abscesses, erythema nodosum. PCR assay of bronchoalveolar lavage and tissue samples. History and physical examination. Primary exposure is often asymptomatic or causes a flu-like illness. Presentation may range from no symptoms to fulminant disease with pulmonary and or extrapulmonary manifestations, fever, weight loss, hepatosplenomegaly, lymphadenopathy, no, non-productive cough, palatal or tongue ulcers, and pancytopenia indicate disseminated infection. The differential diagnoses include atypical bacterial pneumonia, blastomycosis, coccidiomycosis, tuberculosis, sarcoidosis, pneumoconiosis, and lymphoma. Okay. Histohides and macrophages. So histiomacrophage containing numerous yeast cells of Histoplasma capsulatum. Diagnosis. Chest X-ray shows diffuse nodular densities, focal infiltrate cavity and or hilar lymphadenopathy. Chronic infection is usually cavitary. Okay, so cavitations. Urine or serum polysaccharide antigen tests are the most sensitive for making the initial diagnosis of disseminated disease, monitoring response to the therapy, and diagnosing relapse. Culture is also diagnostic: blood, sputum, bone marrow, cerebral spinal fluid. The yeast form is seen with special stains on biopsy, so bone marrow, lymph node, or liver. Okay, so yeast form is seen with special stains on biopsy. Biopsy of bone marrow, lymph node, or liver, or bronchoalveolar lavage. Okay, that's it. Treatment: mild pulmonary disease or stable nodules. Treat supportively in the immunocompetent host. Consider itraconazole. Okay. Chronic cavitary lesions. Give itraconazole for more than 1 year. Okay. Severe acute pulmonary disease or we give it for more than 1 year? No. If they have it for more than 1 year. Feels like I'm giving a comprehension test here. So if mild pulmonary disease or stable nodules, you treat supportively in immunocompetent host. Consider itraconazole. And if it's chronic cavitary lesion, give itraconazole if it's more than 1 year, but they wouldn't know if they had it, right? So more than 1 year, you give itraconazole, I guess. We'll figure it out in UWorld. Severe acute pulmonary disease or disseminated disease. Liposomal amphotericin B or amphotericin B for 14 days, followed by itraconazole for 1 year or longer. Lifelong maintenance therapy with daily itraconazole may be necessary. Coccidiomycosis, a pulmonary fungal infection endemic to southwestern United States, can present as an acute or subacute pneumonia. Oh, forgot this. So key fact, nocardia is a partially acid-fast, gram-positive branching rods found in soil that is a common cause of lung and CNS infection in immunocompromised hosts. TMP-SMX is the treatment of choice. Here's nocardia. It looks like that. Key fact here is consider coccidomycosis in a patient from the southwestern United States whom presents with respiratory infection. Pregnant and HIV positive patients and those of Filipino and African descent are at greater risk for disseminated disease. Okay. Coccidioidomycosis, a pulmonary fungal infection endemic to southwestern United States, can present with as an acute or subacute pneumonia or as a flu-like illness and may involve extrapulmonary sites, including bone, CNS, and skin. Manifestations include erythema multiforme or erythema nodosum, that is, bumps. The incubation period is 1 to 4 weeks after exposure. Pregnant HIV positive patients and those of Filipino or African descent are at greater risk for disseminated disease. History and physical examination. Patients present with fever, anorexia, headache, chest pain, cough, dyspnea, arthralgias, and night sweats. Disseminated infection can present with meningitis, bone lesions, and soft tissue abscesses. Diagnosis. Serology is specific but not sensitive during the first 1 to 2 weeks after infection. Repeat testing can increase sensitivity and the disease can be confirmed with immunodiffusion testing. PCR assays of respiratory specimens have been developed that are highly sensitive and specific. The physician should obtain bronchial alveolar lavage and fungal cultures of sputum, wound exudate, or other affected tissues. Cultures are usually only obtained in hospitalized patients or patients with severe disease, and growth can take 2 days to weeks. Identification of coccidioides spherules can occur with hematooxylin and eosin stain or other special sputums or tissue stains. Chest X-ray findings may be normal or show infiltrates, nodules, cavities, mediastinal and hilar adenopathy or pleural effusion. Treatment here is per oral fluconazole or itraconazole and for mild infection. IV amphotericin B is only for severe and or protracted primary pulmonary infection and disseminated disease, followed by perorazole therapy once stable. So, fluconazole or itraconazole. Chronic. No treatment needed for asymptomatic chronic pulmonary nodules or cavities. Progressive cavitary or symptomatic disease usually requires surgery plus long-term azole therapy for 8 to 12 months. Okay, so that makes sense now. Itraconazole was for more than 1 year. Okay. Blastomycosis. And that was for histo, right? Yes, histo. Now on to blastomycosis, a fungal infection endemic to central and southeastern United States, particularly Mississippi and Ohio River valleys. Okay, so remember where those are. And this one was Ohio, Mississippi River valleys as well. And exposure to bird and bat excrement. And this one, okay. History and PE presents similarly to coccidioidomycosis and typically has extrapulmonary involvement in the bone, prostate, and skin. This is the one that looks like squamous cell carcinoma. And histoplasmosis has palatal ulcers. Okay. So it presents similarly to coccidioidomycosis and typically has extrapulmonary involvement in bone, prostate, and skin. Diagnosis: serologic tests not sensitive enough. Culture is the only way to definitely diagnose, and sputum smear will show broad spectrum budding yeast. Treatment here is treat symptomatic patients with itraconazole and consider inpatient treatment with amphotericin B and intensive care unit. Admission if the condition is complicated by ARDS, meningitis, or other systemic involvement. Mycobacterial infections. Tuberculosis. Infection caused by mycobacterial tuberculosis. Roughly 2 billion people are infected with TB. Global prevalence. In the United States, close to 10,000 new TB cases are identified per year. History and physical examination. The physician should identify risk factors for TB in patient's history, including history of travel to and from high-risk nations, particularly prevalence in the Southeast Asia and Sub-Saharan Africa. Homelessness, incarceration, alcohol use disorder, IV drug use, HIV positivity, and employment in healthcare. Pre-existing lung disease, immunosuppression, and advancing age are also risk factors. Most people who become infected with TB are asymptomatic. This is called latent TB. Symptomatic patients can present as primary or secondary, that is, reactivation of latent TB. Secondary. Most cases of TB are confined to the lungs. Presenting signs include cough, hemoptysis, dyspnea, pleuritic chest pain, fever, weight loss, night sweats, and fatigue. Extrapulmonary TB, more common in patients with HIV, spreads hematogenously and can affect any organ system. Key fact here is management of Montauk's tuberculin skin test is the same for patients regardless of Bacillus chlamydia gorin or BGC vaccination status, but testing with interferon gamma release assay or IGRA is preferred for those who have received the BCG vaccine. Diagnosis: latent disease, asymptomatic, and previous exposure. Okay. Diagnosis with positive tuberculin skin test or interferon gamma release assay. Okay. So skin test and that. Okay. Immunocompromised individuals with latent TB infection may have a negative TST or energy. All patients with positive purified protein derivative require, or PPD, require evaluation with a chest x-ray to rule out active disease. Active disease is mycobacterial. You can diagnose with mycobacterial culture of sputum or blood test tissue for extrapulmonary disease. Is the most accurate test, but can take weeks to obtain a sputum acid fast stain. Okay, this figure yields rapid preliminary results. Okay, so pink rods. If acid fast rods, sorry. It is the best initial test, but it lacks sensitivity. Testing for of three specific specimen obtained 8 hours apart is recommended. If stains are positive, NAT and culture are recommended. If extrapulmonary TB is suspected, sample should be sent for affected sites. The most common findings among typical hosts is a cavitary infiltrate in the upper lobe of chest X-ray. Remember, if you find something like this is the lung. If the cavitation is anywhere over here, it's usually TB, and if it's anywhere over here, it's usually cavitation is due to aspiration. Okay, so which may be accompanied by calcification or one or more nearby lymph nodes, which is called the Gons focus. Patients with HIV, so you might even see that little thing over there or somewhere here. It's still primary TB then. Patient with HIV or those with primary TB may show lower lobe infiltrates with or without cavitation. Okay. Multiple fine nodular densities distributed throughout both lungs are typical of miliary TB. Okay, fine nodular density distributed throughout both lungs are typical of miliary TB, which represents hematologic or lymphatic dissemination. Okay, so here we have a tuberculin test. This is going through the diameter of, or like the length of the induration, and what we find, right? So PVD interpretation. If the bump is 5 to 9 millimeter, it's positive test. If they are HIV risk factors, close tuberculosis contacts, and there is an evidence of TB on chest X-ray, then this is a positive. Otherwise, it's a negative. We don't worry about it. If it's 10 to 14, it's considered positive. They're IV drug user, residents of developing nations, chronic illness, People who live or work in high-risk congregate settings, for example, homeless shelter, nursing homes, or correctional facilities. Okay, otherwise it's a negative, unless they're any of these. And then there is, that was my phone, not yours. Oh, let me just put that on the side. Okay, so all other patients, more than 15 millimeters is true positive, with no known risk factors. Okay. So if they're just 10 mm and then they work in the, I don't know, Midwestern states, and they're farming and they get 10 to 14 mm, it's still a negative, so you don't worry about tuberculosis then. But then if they're one of these, then you worry about it, right? Okay. Okay, so treatment. All cases, both latent and active, must be reported to local and state health department. Okay, latent and active both. Respiratory isolation is in a negative pressure room. Okay, so that means if this is the room, negative pressure, so air is going to be pulled in through the door sills. If it's positive pressure, then it goes out, and if it's neutral, it can go in and out, right? All cases, both latent and active, must be reported to local, local and state health departments. Respiratory isolation in a negative pressure room should be instituted if active TB is suspected, and or all healthcare workers in contact with the patient should wear N95 mask. Okay. Treatment measures are as follows. For latent disease, for a positive PPD without signs or symptoms of active disease, treatment with rifampin for 4 months, or with isoniazid, isonicotinonic acid hydrazide, plus either rifampin or rifampicin for 3 months. Okay, so you give INH plus rifampin. Okay, rifampin for 3 months. This is for latent. Or you can give just latent PD without this treatment with rifampin for 4 months. Or you can give rifampin for 4 months. Okay, for 4 months you give rifampin. Okay, or with isoniazid plus either rifampin or rifampicin for 3 months. Alternative regimen includes INH for 6 months. Okay, so if they don't want rifampin, they don't want rifampin and INH for 3 months, then they're stuck with 6 months of isoniazid, INH. Okay. Active disease, directly observed multi-drug therapy with a 4-drug regimen: INH, pyrazinamide, rifampin, ethambutol. RIPE. RIPE. So for 4 months, first 4 months, you give all 4. For the first 2 months, you give all 4, and for the last 4 months, you give the first 2. Okay. So RIPE. Okay, so again, directly observed multi-drug therapy with a 4-drug regimen: rifampin, isoniazid, pyrazinamide, and ethambutol for 2 months. followed by INH and rifampin for 4 months. High yield side effects of TB medications. Ethambutol can cause optic neuritis. INH can cause hepatitis. Peripheral neuropathy. Consider administering pyridoxine concurrently to prevent this. Okay. Yes, that is an important one. Isoniazid inhibits pyridoxine receptors, I think, or something like that. I forgot the pathophysiology for that, but either ways, if there's some kind of deficiency you're thinking of and they're taking INH, it's from most likely medical adverse effect. Medication adverse effect. Okay, so INH can cause hepatitis, peripheral neuropathy. Consider administering pyridoxine concurrently to prevent this, and a lupus-like syndrome. Pyrazinamide can lead to hyperuricemia or hepatitis, and rifampin turns body fluids orange. Okay, so this is pretty cool. Yes, so ripe treatment. It was given here. Mnemonic for that. Okay. Tuberculosis. Note the red color, red snappers of tubercle bacilli on fast-acting staining. Okay. Water break. Non-tuberculous mycobacteria. These organisms can cause a spectrum of disease, particularly in immunocompromised hosts. Organism can cause spectrum of disease, particularly in immunocompromised hosts. Okay, so Mycobacterium avium complex. This is when you have CD cell count of less than 50. Can cause cavitary lung disease, classically in older patients with underlying chronic lung disease, COPD and CF. Disseminated disease is classically seen in people with HIV and CD cell count of less than 50. Mycobacterium kansasi can also cause cavitary lung disease under similar conditions. Oh, I forgot this cue. A 41-year-old woman returns to emergency department a week after she was discharged for diabetic ketoacidosis treatment. Today she complains of low-grade fever, tenderness, and swelling over her face, and a persistent nasal discharge with occasional blood. Physical examination demonstrates necrosis in the left nasal turbinates and left eye. Propoptosis specimens from the sinuses show broad non-septate hyphae. What is the next most appropriate step in management? Itraconazole? I don't know. Next most appropriate step in management involves surgical debridement and amphotericin B because this patient has mucormycosis. I see. Did they say it was dark? Oh, okay. Necrosis, right. Supposed to pay attention to that. So yeah, you surgically debride it. And amphotericin B. The patient has mucormycosis, a dangerous and aggressive infection found in patients who are diabetic and immunocompromised. Aggressive surgical debridement is warranted. Yes. And okay, back to this. Cavitary lung disease under similar conditions. Other mycobacteria like M. marinum, M. abscessus, M. ulcerans, and M. colonae, I'm sure you can pronounce it better than I, can be isolated in chronic, non-healing wounds. Ubiquitous organisms cause pulmonary and disseminated infection in several demographic groups. The primary pulmonary form occurs in apparently healthy non-smokers, Lady Windermere syndrome. A secondary pulmonary form affects patients with pre-existing pulmonary disease such as COPD, TB, or CF. Disseminated infection occurs in AIDS patients with a CD cell count of less than 50 who are not on highly acute active antiretroviral therapy. Okay, history and physical examination. Disseminated avian infection in AIDS is associated with fever, weight loss, diarrhea, and severe anemia in patients who are not on heart or chemoprophylaxis for MAC. Hepatosplenomegaly and lymphadenopathy are occasionally seen, and adrenal insufficiency is possible in the setting of adrenal infiltration diagnosis. The physician should obtain mycobacterial blood cultures positive in 2 to 3 weeks. Labs show anemia, hypoalbuminemia, and increase in serum alkaline phosphatase and LDH. A biopsy of a lung, bone marrow, intestine, or liver reveals foamy macrophages with acid-fast bacilli. Typical granulomas may be absent in immunocompromised patients. Treatment is treat with macrolide, clarithromycin, or azithromycin plus ethambutol. Okay, so you treat with macrolide um, plus ethambutol with or without rifabutin, and consider heart if the patient is drug naive. Continue for more than 12 months and until CD count cell is more than 100 for at least 6 months. Prevention. Routine MAC prophylaxis is no longer recommended. Okay, that is true. Recommended for HIV patients with CD4 plus cell count less than 50 on heart. It's because it's not as common anymore. Those not on heart should receive chemoprophylaxis and azithromycin. Right. Okay, pneumocystis jirovecii pneumonia, formerly known as pneumocystitis carinii pneumonia or PCP. Risk factors include impaired cellular immunity and AIDS. History and physical examination. Presents with dyspnea on exertion, fever, non-productive cough, tachypnea, weight loss, fatigue, and impaired oxygenation. Subacute weeks with AIDS, acute respiratory failure with immunosuppressive therapy. Can also present as disseminated disease or as local disease in other organ systems. The differential diagnosis includes TB, viral pneumonia, histoplasmosis, and coccidioidomycosis. This diagnosis here is diagnosed by cytology or induced sputum or bronchoscopy specimen with silver stain. That's important. And immunofluorescence. Obtain a ABG to check PaO2. Okay, and this is the classic photo from step 1 that we see. Silver stain of pneumocystis jirovecii. Okay, it's a lung tissue stained with silver, uncovers folded cysts containing coma-shaped spores. Okay, chest X-ray most commonly shows diffuse bilateral interstitial infiltrates with a ground glass appearance, batwing or butterfly pattern, but any presentation is possible. Increase in beta D glucan and increase in LDH can be useful, but our non-specific treatment here is the preferred regimen is high dose of TMP-SMX for 21 days per oral if mild to moderate and IV if severe. Alternate regimens are mild to moderate. You can use trimethorphan plus dapsone or primaquine plus clindamycin or etovaquone. If it's severe, pentamidine or primaquine plus clindamycin. Key fact here is in patients with pneumocystis pneumonia and moderate to severe hypoxemia with PaO2 is less than 70 mmHg or an alveolar arterial oxygen gradient more than 35, and add a prednisone taper to decrease lung inflammation and reduce mortality. The physician should use prednisone taper in patients with moderate to severe hypoxemia, PaO2, and it's like right there. The physician should use a prednisone taper in patients with moderate to severe hypoxemia, PO2 less than 70 mmHg, or an alveolar arterial oxygen gradient. Anthrax, caused by the spore-forming gram-positive bacterium Bacillus anthracis. Infection is an occupational hazard for veterinarians, farmers, and individuals who handle animal wool, hair, hides, or bone meal products. Has been used as a biologic weapon. B. Anthracis can cause cutaneous, most common, inhalation, most deadly, or GI anthrax. There is no person-to-person spread of anthrax. Okay, that's what it looked like. Um, Cutaneous anthrax black Asher is seen on the forearm. History and physical examination. Cutaneous presents 1 to 7 days after skin exposure and penetration of spores. The lesions begin as a periodic papule that enlarges to form an ulcer surrounded by a satellite bulbous lesion with an edematous halo and a round, regular, raised edge. Regional lymphadenopathy is also characteristic. The lesion evolves into a black Asher within 7 to 10 days. Okay, inhalation presents with fever, dyspnea, hypoxia, hypertension, or symptoms of pneumonia 1 to 3 days after exposure, classically caused by hemorrhagic mediastinitis. Patients typically do not have pulmonary infiltrates. GI occurs after the ingestion of poorly cooked, contaminated meat. It can present with dysphagia, nausea, vomiting, bloody diarrhea, and abdominal pain. Diagnosis criteria for diagnosis include culture isolation or 2 non-culture supportive tests, PCR, immunohistochemical staining, or enzyme-linked immunosorbent assay. Chest X-ray is the most sensitive test for inhalation disease. Shows a widened mediastinum and pleural effusion. Here, the best initial treatment is ciprofloxacin. Ciprofloxacin or doxycycline. This is third generation, I believe, or doxycycline plus 1 to 2 additional antibiotics for at least 14 days for inhalational disease or cutaneous disease of the face, head, and neck. Okay, so again, initial treatment best is ciprofloxacin or doxycycline plus 1 to 2 additional antibiotics for at least 14 days for inhalational disease or cutaneous disease of the face, head, or neck. For other cutaneous disease, treat for 7 to 10 days. Post-exposure prophylaxis, ciprofloxacin to prevent inhalation anthrax should be continued for 60 days. Okay. Okay. Acute pharyngitis. I feel like I have this right now. Water. Viral causes are more common, 90% in adults, but it is important to identify streptococcal pharyngitis, group A beta hemolytic streptococcus pyogenes. Etiologies are as follows. Bacterial, group A streptococcus gas, Neisseria gonorrhea, Corynebacterium diphtheria, and pneumonia. Viral, rhinovirus, coronavirus, adenovirus, herpes simplex virus, Epstein-Barr virus, cytomegalovirus, influenza virus, or Coxsackie virus, acute HIV infection. Key fact here is early antibiotic treatment of streptococcal pharyngitis can prevent rheumatic fever but not glomerulonephritis. History and PE. Typical of streptococcal pharyngitis: fever, sore throat, pharyngeal erythema, tonsillar exudate, cervical lymphadenopathy, soft palate petechiae, headache, vomiting, sclerentiform, rash, indicate scarlet fever. Okay. Atypical of streptococcal pharyngitis: coryza, hoarseness, rhinorrhea, cough, conjunctivitis, anterior stomatitis, ulcerative lesions, GI symptoms. Okay, so here pharyngeal erythema with palatal petechiae. Streptococcus pyogenes is the most common bacterial cause of pharyngitis. Okay, diagnosis. Diagnosed by clinical evaluation, rapid gas antigen detection, and throat culture. If 3 out of 4 Centaur criteria are met, the sensitivity of rapid antigen testing is more than 90%. Treatment here is if gas is suspected, begin empiric antibiotic therapy with penicillin for 10 days, cephalosporin, amoxicillin, and azithromycin are alternative options. Symptom relief can be attained with fluids, rest, antipyretics, and saltwater gargles. Okay. Complications. Non-suppurative. Acute rheumatic fever. Post-streptococcal glomerulonephritis. Okay. So modified Centaur criterion. Centaur criteria plus age. Criteria is fever, 1 point. Tonsillar exudate is 1 point. Tender anterior cervical lymphadenopathy is 1 point. Lack of cough, 1. 3 to 14 years of age is 1, and 15 to 45 years of age is 0. More than 45 years of age is -1. So if 4 to 5 points, treat empirically with antibiotics. If 2 to 3 points, perform rapid antigen test. If positive antigen test, treat with antibiotics. If negative antigen test, perform throat culture. If 0 to 1 point, no testing or antibiotics are required. Symptomatic treatment only. Okay. So 1, 2, 3. You do perform rapid antigen test. If positive antigen test, treat with antibiotics. If negative, then perform throat culture. Okay. And if it's any of these, lack of cough is added to it, then you do empirical antibiotics right away. Okay. So I'm guessing this would be the determinant factor and one of these. Okay. Fever, tonsillar exudate, tender anterior cervical lymphadenopathy, lack of cough, then 3 to 14 years is 1, 15 to 45 is 0, and then more than 45 is -1. Okay. Key fact: acute necrotizing mediastinitis is a life-threatening complication of untreated retropharyngeal abscess that presents with fever, chest pain, and dyspnea. If it requires urgent surgical drainage to prevent spread to the posterior mediastinum, which may cause lethal pleural and pericardial effusion. Another key fact is all patients with a history of rheumatic fever should be given routine penicillin prophylaxis to prevent recurrent group A streptococcus infection. So all patients with a history of rheumatic fever should be given routine penicillin prophylaxis to prevent recurrent group A streptococcus infection. Okay. So if we did complication non-suppurative, it's this, and for suppurative, the complications are cervical lymphadenitis, mastitis, sinusitis, otitis media, retropharyngeal or peritonsillar abscess, and there are rarely thrombophlebitis of the jugular vein. It's called the Lemierre syndrome, caused by Fusobacterium, which is an oral anaerobe. Peritonsillar abscess may present with adenophagia, trismus, lockjaw, a muffled hot potato sound voice, unilateral tonsillar enlargement, and erythema, with the uvula and soft palate deviated away from the affected side. Culture abscess fluid and localize the abscess via intraoral ultrasound or CT. Treat with antibiotics and surgical drainage. Oral infection, so treat with that and that. Oral infection, Ludwig angina. This is rapidly progressive cellulitis of the submandibular space that may cause airway compromise from rapidly expanding edema, usually caused by a polymicrobial infection in the setting of poor oral hygiene. IV broad spectrum antibiotics and diligent airway management are necessary. Surgical drainage is performed if there is abscess formation, which is uncommon. Okay, so surgical drainage is performed if there is an abscess. Otherwise, you give IV broad spectrum antibiotics and diligent airway management are necessary. Okay, so that is your Ludwig's angina. Acute lymphadenitis, unilateral and rapid onset, less than 1 week, commonly caused by S. aureus and S. pyogenes, typically involving the submandibular lymph node. Antibiotics are required if symptoms flatulence, fluctuance, yep, fever and cellulitis are present in to prevent abscess formation. This word is tripping me out, yo. Okay. Antibiotics are required if there is fluctuance, fever, and cellulitis are present to prevent abscess formation. Okay, so S. aureus and S. pyogenes can cause acute lymphadenitis. Key. Key fact: Ludwig angina is bilateral cellulitis of the submental, submaxillary, and sublingual spaces that usually results from an infected tooth. It presents with dysphagia, drooling, fever, and a red, warm mouth, and it can lead to death from an asphyxiation. Key fact: potential complications of sinusitis include meningitis, frontal bone osteomyelitis, cavernous sinus, thrombosis, and abscess formation. Key fact: another is beware of invasive and life-threatening fungal sinusitis caused by mucormycosis and rispus. I missed out on that one. Remember, they'll mention that it's either necrotic or there's like a black pigment on it or something like that. In patients with poorly controlled diabetes, mellitus, immune compromise, or neutropenia. Okay, sinusitis. Refer to inflammation of the, water break right here. Drink water, guys. Refer to inflammation of the paranasal sinuses. The maxillary sinuses are most commonly affected. Maxillary ones. Subtype include the following: acute sinusitis, symptoms lasting less than 1 month, most commonly associated with viruses as pneumonia, H. influenza, and M. catarrhalis. Bacterial causes are rare and characterized by purulent nasal discharge, facial or tooth tenderness, hypoxemia, anosmia, and symptoms lasting more than 10 days. Chronic sinusitis, symptoms persisting more than 3 months. A chronic inflammatory process often caused by obstruction of sinus drainage and ongoing low-grade anaerobic infection. Okay, so acute, it lasts less than 1 month. It's most commonly associated with viruses as pneumonia, H. influenza, and M. catarrhalis. Okay, so these are, remember those. And bacterial causes are rare and characterized by purulent nasal discharge. So if there is bacteria involved, then you're going to have purulent nasal discharge, facial or tooth tenderness, hypoxemia or anosmia. Okay, no, you won't be able to smell. And symptoms last more than 10 days. If it's chronic, symptoms are persisted for more than 3 months. Chronic inflammatory process often caused by obstruction of sinus drainage, ongoing low-grade anaerobic infection. Okay. History and physical examination presents with fever, facial pain, pressure, headache, nasal congestion, and discharge. Examination may reveal tenderness, erythema, and swelling over the affected area. High fever, leukocytosis, and a purulent nasal discharge are suggestive of acute bacterial sinusitis. Diagnosis: a clinical diagnosis, culture, and imaging are generally not required for acute sinusitis but may guide the management of chronic cases. Translumination shows opacification of the sinuses. Low sensitivity. CT is the test of choice for sinus imaging but is usually necessary only if symptoms persist after treatment. Okay, so it is a clinical diagnosis, but culture and imaging are generally, culture and imaging are not generally required for acute sinusitis, but may guide the management of chronic cases. You can do transillumination, which shows opacification and sinuses. It's low sensitivity. CT is test of choice, but is usually not necessary. If only if symptoms persist after treatment, you do the CT scan. Sinusitis, coronal CT imaging shows a opacified left maxillary sinus and marked associated bony thickening consistent with chronic maxillary sinusitis. Okay, treatment. Most cases of acute sinusitis are viral and or self-limited and are treated with symptomatic therapy, decongestants, antihistamines, nasal saline lavage, and pain relief. Okay, so this is going to be your symptomatic therapy. Acute bacterial sinusitis. The physician should consider either amoxicillin, clavulanate, or gentamicin. Augmentin. That's what this is called. For 10 days, or clarithromycin, azithromycin, trimethorprim, sulfamethoxazole, so TMP-SMX, a fluoroquinolone, or a second-generation cephalosporin for 10 days. Chronic sinusitis. Antibiotics like those used for acute disease may be prescribed for chronic sinusitis, although a longer course, which is 3 to 6 weeks, may be necessary. So antibiotics that are used for acute may be prescribed here as well, so you don't have to remember difference that's here. Okay, but you give it for longer time, like 3 to 6 weeks. Ooh. Adjuvant therapy with intranasal corticosteroids, decongestants, and or antihistamines may be useful in combating the allergic inflammatory component of the disease. Surgical intervention may be required. Okay, let's take a break here and we'll continue from hemoptysis. Welcome back to hemoptysis. Hemoptysis is the expectoration of blood from the lower respiratory tract below the vocal cords, which can be caused by various etiologies. These etiologies can be divided into life-threatening and non-life-threatening hemoptysis. Bleeding from the pulmonary arteries' low-pressure system is commonly non-life-threatening, whereas bleeding from the bronchial arteries' high-pressure system may be life-threatening. Hemoptysis is often classified as mild, less than 30, moderate, 30 to 100, and severe, 100 to 600 ml, or massive. Massive hemoptysis is defined by a number of criteria, often ranging from 100 ml to more than 600 ml over 24 hours, with respiratory or hemodynamic compromise. Etiologies of hemoptysis are airway disease, bronchitis, bronchiectasis, bronchial neoplasm, foreign blood bodies, pulmonary parenchymal disease, infection such as TB, rheumatic and immune disorders such as vasculitis, connective tissue disorders such as Ehlers-Danlos syndrome, pulmonary vascular disorders, elevated pulmonary capillary pressure, pulmonary arteriovenous malformation, pulmonary embolism, and bleeding disorders. History and physical examination assess for risk factors for specific disease such as lung cancer in patients with heavy smoking history. Rule out life-threatening hemoptysis and observe for airway compromise. Diagnosis: orders chest x-ray first and consider CT imaging of the chest if needed to rule out specific etiologies. CBC, coagulation studies, urine analysis, rheumatic workup should be performed as needed. Over here we have evaluation of hemoptysis. So low suspicion of other oropharyngeal or GI causes. Life-threatening features are massive, more than 100 ml per hour or more than 150 ml per 24 hours. Respiratory distress, hemodynamic instability. If this is present, then you secure airway, breathing, and circulation. Treat with bronchoscopy, IR embolization, or resuscitation. Resection. Massive. So this is the most common cause of massive hemoptysis: bronchiectasis, active pulmonary TB, and malignancy. If these symptoms are not present and you still have it, then you do lab, chest x-ray, CT scan of the chest with or without contrast, bronchoscopy if normal imaging, or if no other etiologies identified, then evaluate and treat findings. Okay. Treatment. In the case of impeding airway compromise due to massive hemoptysis, secure the airway by placing an endotracheal tube while evaluating the cause. Management of hemoptysis includes hemodynamic stabilization and treatment of the underlying cause. In the case of persistent bleeding, bronchoscopy interventions and embolization can be performed to control the bleeding. Okay, so here, in case of impeding airway compromise due to massive hemoptysis, secure the airway by placing an ET tube while evaluating the cause. And management of, if there is one, then includes hemodynamic stabilization and treatment of underlying cause. In the case of persistent bleeding, bronchoscopy intervention and embolization can be performed to control the bleeding. Okay, so here we do labs, chest x-ray, CT scan. If nothing's found, then you go to bronchoscopy if normal imaging, or if no other etiologies are identified. And if there is a source of bleeding, then you go into this. Treat with bronchoscopy, IR embolization, and resection. Okay. Pleural disease. Pleural effusion. An abnormal accumulation of fluid in the pleural space, classified as follows. Transidate. If transidate is secondary to increased pulmonary capillary wedge pressure or decreased oncotic pressure. Okay. And exudate is secondary to increased pleural vascular permeability. See this for an algorithm showing etiology of pleural effusion, and this table lists the possible causes of both the transidate and exudate. Okay. History, physical examination. It presents with dyspnea, pleuritic chest pain, and or cough. Exam reveals dullness to percussion and decreased breath sounds over the effusion. A pleural friction rub may be present. Diagnosis: best initial test, chest x-ray, blunting of the costophrenic angle, lateral decubitus, decubitus view is most sensitive. It also is used to assess for loculation. Okay. Water break here. Diagnosis: thoracocentesis. Lights criteria: pleural protein plus serum protein more than 0.5, pleural LDH plus serum LDH more than 0.6, pleural LDH more than 2/3 of the upper limit of normal serum LDH. Okay, so we do Lights criteria for pleural effusion. Right. So if you do pleural protein plus the serum protein, and it's more than 0.5, That means it meets more than one of these criteria, one or more, and it's exudative. Was it plus or divide? I think it was divide. Okay. If it's exudative, yeah, these should be dividing, not plus. Okay. Exudative. Intrathoracic, extrathoracic. Okay, just check the book. Okay. Exudative, so it could be intrathoracic or extrathoracic. If it's extrathoracic, right-sided, then Meigs syndrome. Meigs syndrome, that's the one with ascites, pleural effusion, and there was something else with it too. And endometriosis. Then there's left-sided pancreatitis and esophageal rupture. Right, I think it was fibromas. Oh, I don't remember, but Google it. Left-sided pancreatitis and esophageal rupture. It requires further workup. For example, pleural fluid analysis, culture, AFB, TB antigen, RF, CCP, ANA. If it's intrathoracic, it's going to be either infection, neoplasm, autoimmune, for example, RA, SLE, drugs, pulmonary embolism, chylothorax, hemothorax, and yeah, hemothorax. So again, further workup, for example, pleural fluid analysis culture, AFB, TB antigen, RF, CCP, ENA. If like criteria is not met, then it's transudative. So it could be increase in hydrostatic pressure, causes are congestive heart failure, ESRD, pulmonary embolism, early stage. You treat the underlying cause. If it's transudative and there's decrease in oncotic pressure, the causes are cirrhosis, nephrotic syndrome, then again you treat underlying causes. Right, cirrhosis makes albumin, so if there is decreased amount of albumin, oncotic pressure is decreased. If there's nephrotic syndrome, it leaks out protein, albumin, so again decrease in oncotic pressure. So causes of pleural effusion, transudative, congestive heart failure, cirrhosis, nephrotic syndrome, exudative, pneumonia, TB, malignancy, PE, SLE, pancreatitis, trauma, chylothorax, pulmonary physical examination. Okay, so lung consolidation, pleural effusion, and pneumothorax. We'll go through lung consolidation. The percussion will be dull. There will be increase in tactile fremitus. Breath sounds, this is the only one where tactile fremitus is increased. So if throughout the vignette they mention that tactile fremitus is increased, it's going to be consolidation. For example, lower pneumonia. Breath sounds are bronchial. Voice transmission, bronchophony and egophony is heard. Again, this is classic presentation for lung consolidation and not the pleural effusion or pneumothorax again. And crackles are present here as well. So pneumonia. Pleural effusion, percussion is dull. There's no tactile fremitus. There's decrease in tactile fremitus, decrease in breath sounds, decrease in voice transmission, and crackles are absent. How do you differentiate it with pneumothorax? Well, pneumothorax is hyperresonant. However, there is decrease in tactile fremitus, breath sounds are decreased or absent, voice transmission is decreased, and crackles are absent. So if it's bronchial, it's lung consolidation, breath sounds. If it's decreased breath sounds, it's pleural effusion. If it's absent, it could be pneumothorax. Okay. If it's decreased, it could be pleural effusion or pneumothorax, but if it's absent, it's definitely pneumothorax. Okay. Cool. On to like criteria for pleural effusion measure. So yeah, so pleural protein, you take the protein inside, divided by serum protein. Obviously, pleural protein is usually less than the one you find in serum because there's abundance of protein in the serum. So lower number is on top, less than 1, right? But if you have a value that's more than 0.5, then it's exudative. Okay. Pleural LDH and serum LDH, same scenario. It's going to be low. But if you have more than 0.6, it's exudative. Okay. And LDH more than 2/3 of the upper limit normal serum LDH, exudative. So an effusion is an exudative. An effusion is an exudative if any of the previous criteria are met. So pleural over serum. Okay, you always put the one that's in abundance at the bottom denominator, and then you put the lower number on top when you're dealing with Lyse criteria. Pleural LDH over serum LDH. Pleural fluid LDH more than the 2/3 of the upper limit of normal serum LDH. Okay. So next step, thoracentesis. We are talking about what? Diagnosis. So diagnosis best initial test is chest X-ray, blunting of the claustrophrenic angle. Remember, if this is the lung, they show normally it's like this, the diaphragm, but here you won't see any diaphragm because all of this is censored out by white opacities, like that. So that's called blunting of claustrophrenic angle. Lateral ubiquitous view is most sensitive. It also is used to assess for loculation. Okay, next step, thoracentesis. It is indicated for new effusions more than 1 centimeter in the ubiquitous view, except for bilateral effusions and other clinical evidence of congestive heart failure. Using Lyse criteria can determine if the effusion is transitive or exudative. And transitive effusion typically have a pH of 7.4 to 7.55. Exudative effusion typically have a pH of pH less than 7.4. Effusion is exudative if, okay, so the more acidic, it's exudative. Okay. Effusion is an exudate if it meets any Lyse criteria. Exudative effusion require further workup, pleural fluid glucose, amylase, cytology, 666. Cell count, culture, gram stain, AFB, TB, antigen, RF, CCP, ANA. Complications, paranpneumonic effusion and empyema. Pleural effusions that arise as result of pneumonia, lung abscess, or bronchiectasis. Okay, this table. Recurrent effusion. Treatment here is treat the underlying cause of effusion. See table this. For treatment, paranpneumonic effusions and empyema. Recurrent effusions may require pleurodesis procedure to obliterate pleural space. So let's give that table a look. Okay. Paranpneumonic effusion and empyema. Uncomplicated paranpneumonic effusion. Etiology is fluid movement into pleural space caused by inflammation associated with pneumonia. Appearance is clear and cloudy. pH is going to be more than 7.2. Glucose is going to be normal or decrease, and LDH's ratio is going to be more than 0.6. Okay, so here this is normally exudative finding, and this is usually exudative finding as well, and this is also exudative finding. So okay. Paranpneumonic effusion and empyema. So how do you differentiate between effusion and empyema? That's what we're trying to figure out from this. Okay, so pH more than 7.2, glucose is normal, decrease LDH more than 0.6. Pleural fluid gram stain and culture is going to be negative. Okay, so if you're giving exudative type stuff, but then pleural fluid gram stain is coming out negative, you still treat it with antibiotics because it's pointing towards uncomplicated parapneumonic effusion. In complicated parapneumonic effusion, you'll have persistent bacterial invasion into pleural space. Here, fluid movement into pleural space caused by inflammation associated with pneumonia, right? So, similarly to how sepsis increases transmembrane movements, similarly, pneumonia will also do the same because it is an infection and increase transmembrane movement or transpulmonary space movement. Okay, so here, complicated persistent bacterial invasion into pleural space. Appearance is cloudy. Pleural fluid analysis is pH is going to be less than 7.2, so more towards acidic. Glucose is going to be decreased because it's bacterial. They like glucose. They feed on it, I guess. And LDH ratio is going to be more than 0.6. Okay, so that's exudative. Okay. When I say this stuff, I'm just thinking out loud so that I remember these things. Okay, that's not necessarily true because I don't know. Pleural fluid gram stain and culture. It's going to be negative. Treatment is going to be antibiotic and chest tube as well. Okay. Okay. Empyema. This is bacterial colonization of the pleural space. So here the appearance is going to be purulent. pH is going to be less than 7.2. So that's exudative. Yes. Glucose is going to be decreased. LDH is going to be more than 0.6. So LDH is more than 0.6 for all three of these. pH is more for more than 7.2 for uncomplicated, but other than that, both of these are lower than 7.2. And glucose is decreased in all of them, but it could be normal and uncomplicated. Okay. And it's purulent. So if it's purulent, it's easy to remember that it's empyema because it's plus C type thing. You see, pleural fluid gram stain and culture, it's going to be positive in empyema. And treatment is, again, antibiotics and chest tube. All right. So here, uncomplicated is because of the fluid moving into the space. It's going to be clear or cloudy. pH is increased, so that's the defining feature here. And there's no bacteria. Here, there's no bacteria in the gram stain, but pH is less than 7.2. This is because persistent bacterial invasion into the pleural space. Okay, but it's not enough to show up in the gram stain. Okay, and empyema is empyema. Okay, so to pneumothorax. Here, the key fact first is complicated parapneumonic effusions necessitate chest tube drainage. Mnemonic, presentation of pneumothorax, P-thorax, pleuritic pain, tracheal deviation, hyperresonance, onset sudden, reduced breath sounds and dyspnea, absent fremitus, asymmetric chest wall, and X-ray showing collapse. Okay. Collection of air, actually, water break. Okay, so collection of air in pleural space that can lead to pulmonary collapse. Etiologies are the following. Primary spontaneous pneumothorax due to rupture of subpleural apical plebs, usually found in tall, thin, young males. Secondary pneumothorax due to COPD, trauma, infections, TB, P. Girovici, and iatrogenic factors, thoracentesis, subclavian line placement, positive pressure, mechanical ventilation, bronchoscopy, and biopsy. Tension pneumothorax, a pulmonary or chest wall defect acts as a one-way valve, causing air trapping in the pleural space. Buildup of air pushes the mediastinum to the opposite side of the chest, which can obstruct venous return to the heart, leading to hemodynamic instability and even cardiac arrest unless immediately treated. History and PE. Pneumothorax presents with acute onset of unilateral pleuritic chest pain and dyspnea. Examination reveals tachypnea, diminished or absent breath sounds, hyperresonance, decrease in tactile primitives, and JVD, the secondary to compression of the SVC. Tension pneumothorax presents with respiratory distress, hypoxia, tracheal deviation, and hemodynamic instability. Diagnosis: the diagnosis of a tension pneumothorax should be made clinically. Chest X-ray shows the presence of a visceral pleural line and or lung retraction from the chest wall, best seen in expiratory films. In an emergency department or ICU settings, bedside ultrasound can be used, and it has high sensitivity and specificity. Here, key fact is treatment of a tension pneumothorax requires needle decompression first and then chest tube placement. Okay. We did that. Treatment: tension pneumothorax requires immediate needle decompression second to intercostal space at the mid-clavicular line, followed by chest tube placement. To do it on the side of the pneumothorax. Small pneumothorax, less than 2 centimeters, observation with or without supplemental O2. It may reabsorb spontaneously. Okay, so if it's small, just observe and supplement O2 because it might eventually just get reabsorbed. The air. Large, more than 3 centimeters, symptomatic pneumothorax, needle aspiration or small bore chest tube placement. Patients who are unstable or who have recurrent pneumothorax, chest tube placement. So patients who are unstable or who have recurrent pneumothorax, give a chest tube placement. Place that. Okay. Pulmonary sleep disorder. Here, pneumothorax. See how this is a little larger. It goes this way. Pneumothorax CT shows collapsed left lung. Oh, left lung. Yes. So this should be this way. Right? Yes. So it should be this way. Anyways, yeah, so that way. This image is not, I can't make it out. So anyways, oh, okay. They're talking about this one. Okay, got it. So tension pneumothorax over here somewhere. So it's probably this, but here there's collapse on this side. And these images are bad, so I can't see it. OSA, obstructive sleep apnea, is a sleep disorder characterized by transient obstruction of the upper airway that causes hypoxemia. Etiologies can be central, for example, stroke, secondary, for example, obesity, or it can be mixed. Risk factors include male sex or older age, obesity, craniofacial abnormalities, upper airway abnormalities, adenotonsillar hypertrophy, like children, sedative use, for example, alcohol, benzodiazepine, smoking, and many others. History and physical examination. Cardinal features: irregular respiratory pattern during sleep, obstructive apneas, hypopneas, or respiratory effort-related arousals. Daytime symptoms related to poor sleep, somnolence, fatigue, poor concentration, morning headaches, signs of disrupted sleep, snoring, gasping, choking, restlessness. Key fact here. Did I miss any key facts up here? Just this one. Treatment of tension pneumothorax requires needle decompression first and then chest tube placement. Okay. Key fact: the Stop Bank Survey is a clinical questionnaire that can be used to assess the risk of OSA and for direct further sleep testing. Snoring, tiredness, observed stop in breathing, increased blood pressure, body mass index is more than 35, age is more than 50, neck circumference is more than 40, male gender, the presence of more than 3 positive items should prompt sleep testing. Complications: increase in cardiovascular morbidity, systemic hypertension, that was primary something hypertension, group 1, right? So increase in cardiovascular morbidity, systemic hypertension, PAH, coronary artery disease, arrhythmias, heart failure, polycythemias, and stroke. Increase in risk for insulin resistance and type 2 diabetes mellitus. Increased risk for motor vehicle collisions caused by impaired alertness. Diagnosis: best initial test, polysomnography, sleep test based on apnea, hypoapnea index, AHI equals apneas plus hypoapnea's total number of hours of sleep and presence or absence of related symptoms. Diagnosis is confirmed with the following: AHI more than 5 plus symptoms, or AHI more than 15 regardless of the symptoms. Okay. Again, best initial test is polysomnography based on the apnea hypoapnea index. AHI is equal to apneas plus hypoapnea and total hours of sleep. Okay, and presence of absence of related symptoms. Diagnosis is confirmed with the following: if it's more than 5 plus PLUS symptoms. Okay, so they just put that here without explaining what this is. Why am I reading this book if you're not going to explain it? The AHI more than 5 plus symptoms. AHI for more than 15 regardless of symptoms. Okay, so AHI score. Okay, that's what they're talking about. But I don't know what the plus means. Oh, okay, so if they have this and plus they have the symptoms, but then why is this in capitals? Okay, anyways, I'm just gonna move on. Treatment: best initial therapy, weight loss if applicable, and CPAP. Alternatives: oral appliances, hypoglossal nerve stimulation, and maxillomandibular advancements. Bone of upper and lower jaw surgically repositioned to relieve obstruction. Last resort is tracheostomy. Okay. Ooh. Intense. Okay, so weight loss is the best initial therapy and CPAP machine. Alternate is oral appliances, hypoglossal nerve stimulation, and maxillomandibular advancement. Okay. Obesity hypoventilation syndrome, or OHS. Obesity hypoventilation syndrome is a sleep disorder defined as awake alveolar hyperventilation in an obese individual that cannot be attributed to other conditions associated with alveolar hypoventilation. History and physical examination. Presents with hypersomnolence and obesity. OHS is further characterized by coexisting sleep disturbances. OHS and OSA. 90% of the patients with symptoms of ASA. See earlier section. OHS with sleep-related hypoventilation. 10%. Patient presents the same as OHS plus OSA, but witnessed apneas during sleep are uncommon. Diagnosis of exclusion. Patients must meet all of the following criteria: obesity, it has to be a BMI of more than 30. Awake alveolar hypertension, PaCO2 more than 45. Hypoventilation, sorry. So awake alveolar hypoventilation, they have a PaCO2 of more than 45. Exclusion of alternative causes of hypercapnia and hypoventilation. Treatment here is best initial treatment: weight loss and non-invasive positive airway pressure, OHS plus OSA, CPAP. Initiate bi-level positive airway pressure if initial management with CPAP fails, and OHS plus hypoventilation, then BiPAP. So again, best initial treatment, weight loss, and in non-invasive positive airway pressure. So PEP, OHS, and OSA, then CPAP, and initiate bi-level positive airway pressure if initial management of CPAP fails. So first comes PEP, then CPAP, then BiPAP. Okay. Next best treatment is bariatric surgery and tracheostomy for last resort. Nose and throat. Rhinitis. Rhinitis is characterized by symptoms of rhinorrhea, posterior or anterior nasal congestion, sneezing, and itching. Although most forms of rhinitis involve inflammation, some forms such as vasomotor rhinitis do not. It may be further classified into allergic and non-allergic causes. Allergic rhinitis pathogenesis results from IgE-mediated type 1 hypersensitivity reaction of the nasal mucosa, commonly associated with atopic disease such as asthma and eczema. History and physical examination presents with rhinitis in response to allergens based on temporal pattern can be further classified as follows: intermittent seasonal allergic reactions to grass, trees, or pollen. Hay fever occurs in late spring or summer. Persistent and perennial annual allergic reactions to house dust, dust mites, molds, dogs, cats. Food allergens may also be contributory. However, evidence is lacking. Diagnosis. Clinical diagnosis based on typical history and nasal examination. Skin prick test involves introducing common allergens into the skin to observe for hypersensitivity reactions. This can help identify allergens. Serum total IgE is generally increased. Serum radio allergosorbent test, RAST, is a blood test that identifies IgE antibodies to specific allergens. Treatment here is allergen avoidance. Medications are second generation oral non-sedating antihistamines such as loratadine, cetirizine, and fexofenadine. Intranasal steroids such as fluticasone, beclomethasone, or mometazone. Nasal spray titrated to minimum effective dose. Sometimes these internal steroids may be combined with intranasal antihistamines. Leukotriene antagonists such as montelukast. This is also beneficial with concomitant asthma. Immunotherapy, allergen exposure, and desensitization. Non-allergic rhinitis. Non-allergic rhinitis is a subtype of rhinitis without an allergic or infectious cause. It accounts for up to 50% of the cases of rhinitis in adults. Etiologies: pathogenesis, irritants, cigarette smoke, pollutants, occupational chemicals such as cleaning products. Vasomotor caused by increased blood flow through to the nasal mucosa. It is instigated by temperature changes or dry air and irritant odors. Gustatory: clear rhinorrhea after ingestion of food, most often spicy. Drug induced due to hypertensives due to antihypertensives, NSAIDs, PDE5 inhibitors, or cocaine. Hormonal rhinitis onset during pregnancy. It revolves with end of pregnancy. It resolves, sorry. It resolves with end of pregnancy. Okay, and senile rhinitis, also called atrophic sinusitis, occurs in older adults when the venous glands that produce moisture fails to function adequately. Diagnosis workup to exclude allergic rhinitis. See earlier information. Treatment is symptom driven. The patient should avoid any precipitating factors. Intranasal corticosteroid, for example, fluticasone, and intranasal antihistamine like azilestine, alone or in combination, treat nasal congestion, postnasal drip, rhinorrhea, and sneezing. Intranasal anticholinergics, ipratropium, treat rhinorrhea. Decongestants, for example, phenylephrine, oxymetazoline, help with nasal congestion. Nasal irrigation and intranasal capsaicin may help. So this was for non-allergic rhinitis, and this was for allergic rhinitis. Okay, so steroids and antihistamines, and leukotriene if needed. Nasal polyps. Nasal polyps are benign outgrowth of. Did I miss any key facts? No. Okay. Nasal polyps are benign outgrowth of nasal mucosa, and they represent the most common tumors of the nasal cavity. They commonly occur in association with allergic rhinitis, acute and chronic infection, and cystic fibrosis. History and physical examination. Patients present with nasal obstruction, postnasal discharge, congestion, sneezing, rhinorrhea, hypoxemia, and anosmia. Important association is aspirin allergy, sinus infection, and asthma. Okay. Diagnosis. Coronal sinus CT scanning is first line imaging modality. Endoscopy can sometimes be helpful for evaluation in the clinic. Nasal masses that do not appear typical or respond to treatment should be biopsied. Treatment. Medical treatment is oral corticosteroids are the most effective. Intranasal corticosteroids, mometasone, piclomethasone, are less effective. Okay, so intranasal are less effective. Okay, and oral are more effective. Other medical options include leukotriene antagonists, montelukast, or IL inhibitors, dupilumab. Surgical removal is indicated in select cases due to severe symptoms of obstruction or infection refractory to medical treatment. The physician should concomitantly treat predisposing factors, for example, underlying allergy. Epistaxis, bleeding from the nose, may either. Yes, okay. So, epistaxis. This is a new topic, okay. Bleeding from the nose may either be anterior or posterior based on the location of bleeding. Anterior epistaxis, this is the most common, 90%, and tends to be self-limited. Bleeding is most often from the Kesselback plexus, for example, the area of anastomosis of the septal branch of the anterior ethmoidal artery. So, there's the mouth. Okay, anterior ethmoidal artery. The lateral nasal branch of the sphenopalatine artery. And the septal branch of the superior labial branch of the facial artery. And there's a superior or inferior sphenopalatine artery or something like that down there. So anterior ethmoidal artery, the lateral nasal branch of sphenopalatine artery, and the septal branch of the superior labial branch of the facial artery. Posterior epistaxis. This is the less common, 10%, and may result in significant hemorrhage. Bleeding occurs from the posterior lateral branches of the sphenopalatine artery and rarely the carotid artery. The treatment here is, if conservative treatment is effective, perform rhinoscopy to localize source to anterior versus posterior. If it's posterior bleeding, then posterior packing is needed. Balloon Foley catheter. Consider admission and ENT consultation. If it's anterior bleeding, then chemical or electrical nasal cautery. Anterior packing like tampon, balloon, or gauze. If that is still ineffective, then perform bilateral nasal packing. If that is also ineffective, consider and treat as posterior source. Okay, and yes. Etiologies. Local causes of epistaxis include mucosal irritation, nose picking, dry air, rhinitis, foreign body, facial trauma, intranasal drugs, cocaine, intranasal corticosteroids, or tumors. Nasopharyngeal carcinomas. Systemic conditions or drugs may also cause epistaxis, for example, anticoagulation, antiplatelet medications, alcohol, bleeding disorders, for example, von Willebrand disease, vascular malformations, nasal hemangioma, or hypertension. Treatment here is initial assessment and resuscitation. Assess and treat for resuscitation. Assess and treat for airway breathing and cardiovascular fluid resuscitation. Redundant large bore IV lines are indicated. Compromise. Okay, so cardiovascular compromise. Okay. Uh, Target history to rule out conditions that predispose to bleeding, detailed earlier. Lab test, coagulation studies for anticoagulated patients, CBC, type, and cross. Initial conservative treatment is positive. Patient elevate body and bend forward. Administer topical vasoconstrictor. For example, oxymetazoline and local anesthetic, lidocaine, and pinch nostrils for 10 to 15 minutes. Apply cold compress. If conservative measures fail, examine nose to look for source of bleeding, rhinoscopy, speculum. Subsequent treatment of anterior bleeding. Cauterization. This is considered first line. Either chemical silver nitrate or electrical cautery is possible. Nasal packing, we already went over this. Nasal tampon, ribbon gauze, or nasal balloon catheters that can be used. If unilateral packing ineffective, bilateral nasal packing can be performed. Subsequent treatment of posterior bleeding, balloon catheter is preferred. Alternatively, a Foley catheter can be used. These patients may be required hospitalization and urgent ear, nose, and throat consultation. So notice how they said position the body, elevate the body, and bend forward, not backwards, right? So don't ask them to lift up their chin, right? Let the blood flow through and out. You don't want it to pool inside. Okay, complication, prolonged retention of nasal packing more than 72 hours increases the risk of complications including necrosis, toxic shock syndrome, sinus and nasolacrimal infection, and dislodgement. A key factor here is brisk bleeding. Even after adequate nasal packing may indicate a posterior source of bleeding. And key fact, consider toxic shock syndrome in patient with fever, hypertension, desquamation, and mucosal hyperemia after receiving nasal packing. Adenotonsillar hypertrophy. Adenoids develop at the posterior surface of the nasopharynx and grows to a final size at 6 to 7 years of age. Palatine tonsils are located towards the end of the soft palate. Both structures are dense in B and T lymphocytes and play a role in local immunity and in host immune defense. Adenotonsillar hypertrophy is characterized by recurrent infections and hypertrophy of the lymphoid-rich structures. History and physical examination. Adenotonsillar hypertrophy usually manifests in children as recurrent infections and sleep disorder breathing, SDP, and B. Adenoid hypertrophy. History of mouth breathing, hyponasal voice, adenoid facies, rhinorrhea, and postnasal drip is commonly described. Tonsillar hypertrophy, high history of recurrent infection, most commonly viral and then bacterial, and airway and feeding difficulties such as dysphagia and SDB, sleep disorder breathing with OSA, voice changes and dental malocclusion may be seen. Sleep disordered breathing. History of excessive daytime somnolence, failure to thrive, enuresis, poor school performance, and or behavioral disturbance due to chronic sleep deprivation. Diagnosis here is adenoid hypertrophy. Rule out other causes of snoring and SDB, such as anterior nasal obstruction. Best diagnostic test here is nasopharyngoscopy to visualize the hypertrophied adenoid tissue. Other lateral x-ray of the neck to visualize the adenoids. Tonsillar hypertrophy. Tonsil grading by physical exam is informative. SDB, best diagnostic test, polysomnography. Okay, treatment here is infection should be first treated with a supportive treatment as needed. Pain control, adequate fluid intake, antibacterial if streptococcal infection is suspected. Use modified Centaur criteria to decide on the use of antibiotics against S. pyogenes. Most common bacterial pathogen. Absence of cough, swollen tender anterior cervical lymph nodes, Temperature is more than 38 degrees Celsius or 100.4. Tonsil exudate and age of individual. Okay. Patients with recurrent infections, more than 7 episodes in the preceding year or more than 5 in the preceding 2 years or more than 4 in the preceding 3 years, consider tonsillectomy. Patients with obstructive SDB diagnosed by polysomnography perform adenoidectomy and tonsillectomy. And acute and chronic laryngitis. Laryngitis results from laryngeal inflammation due to several factors: excessive coughing, infections, vocal abuse, strain. Oh, what I'm doing right now. Gastroesophageal reflux, irritants such as smoking. Chronic and laryngitis usually results from multiple factors, leading over time to persistent inflammation. History and physical examination: acute less than 3 weeks of hoarseness, chronic is more than 3 weeks of hoarseness, and history of chief complaints reveals aforementioned inciting factors. Diagnosis: here are perform physical examination of the head and neck. Lymph nodes can be suggestive of malignancy. In select cases, perform nasopharyngoscopy to visualize the vocal cords, lesions on the vocal cord such as polyps or nodules, bilateral motion of the vocal cords, and edema. Treatment here is supportive. Management is often needed with vocal hygiene. Absolute silence is not required. Hydration, cough suppression, and avoidance of precipitating irritating factors such as smoking. Proton pump inhibitors are needed if reflux is suspected or diagnosed. So for this, there's no help for me. Just hydration, cough suppression, and avoidance of precipitating irritating factors such as smoking. And doing a read with me sessions. Laryngopharyngeal reflux. Reflux of caustic gastric contents causing irritation of laryngeal tissue related to resting upper and lower esophageal sphincter tone and also to duration, magnitude of increased intra-abdominal pressure. For example, obesity would cause chronic increased intra-abdominal pressure. Okay. History and physical examination: dysphonia, cough, globus, throat clearing, dysphagia. Diagnosis largely based on clinical signs and symptoms. Treatment here is dietary changes, avoidance of caffeine, chocolate, peppermint, alcohol, and acidic foods. Behavioral changes, avoidance of smoking, waiting 2 hours after eating for vigorous exercise, avoidance of eating, drinking 3 hours before sleep, and acid suppression, proton pump inhibitors, and H2 antagonists. Benign and malignant laryngeal lesions, vocal cord polyps. Most common benign laryngeal lesions typically caused by vocal cord overuse. For example, singers, teachers, smoking, and or GERD. History and PE: presents with hoarseness and in severe cases dyspnea. Laryngoscopy and stroboscopy is for diagnosis and treat with voice therapy and microsurgery. Vocal cord nodules typically caused by vocal cord overuse. For example, singer and teachers. Smoking and or GERD presents with hoarseness. Diagnosis: laryngoscopy or stroboscopy. Treatment here is voice therapy, smoking cessation, PPI. If GERD symptoms present, steroid injections and microscopy. Recurrent respiratory papillomatosis. Recurrent respiratory papillomatosis is a rare disease caused by human papillomavirus infection of the upper airway, resulting in warty growth. In about 3% to 5% of the patients, malignant transformation to squamous cell carcinoma may occur. The juvenile form is due to peripartum transmission from an infected mother. Children may need up to 20 repeat procedures during their lifetime, causing significant morbidity. However, remission may occur after several years. The adult form is probably transmitted through oral sex. Water break. I'm out of water. The adult form is probably transmitted through, so they're not sure, transmitted through oral sex. Risk factor, juvenile form, triad of being firstborn, vaginal delivery, and mother's age is less than 20 years. Other risks include lower socioeconomic status. The physician should consider sexual abuse in children older than 5 years. Adult forms, yikes. Adult form, more lifetime sexual partners and increased frequency of oral sex. Okay. History or PE. Hoarseness most common, voice change, episodic choking, foreign body sensation, cough, dyspnea, inspiratory wheeze, and stridor. Diagnosis, laryngoscopy or bronchoscopy. Treatment, there is no cure. Repeated surgical debulking is mainstay of the treatment. Cidofovir is injected in resection site in select patients. Subcutaneous interferon therapy may be useful as second line. Tracheostomy is used for significant airway obstruction, and prevention is through quadrivalent HPV vaccination. And that's it. Whew.